طيب بسم الله الرحمن الرحيم. Welcome to ERA Easy Radiology Approach. Today we have VIVA Session 21 and 22. We have today Dr. Fathallah Awad, one of the pioneers, one of the consultant radiologists, very expert in the genitourinary field and musculoskeletal. Let's start by the first case. And before starting, if you want to interact with us, you can join our WhatsApp group or Telegram channel to interact freely with us, inshallah. Okay.
This is trauma case CT, chest, abdomen. Just I will have scroll. Okay. And then I will start to comment. Okay. And appreciate some effusion noted in the bright hemisthorax, pleural effusion.
Okay.
I will go down and just to look for any abnormality. Okay, no free fluid I could appreciate in the abdomen, but just I can appreciate that there is evidence of here in this region, in the hepatorenal pouch, right hepatorenal pouch, there is evidence of abnormal hypertension, which may be from, yes, it's at the level of the right adrenal gland.
Okay.
So it could be adrenal hematoma.
Okay.
I'm just trying to look if there is any other evidence of abnormality in the liver or in the kidney. I couldn't really appreciate lacerations noted in the liver. Okay. And
where is the laceration of the liver?
I couldn't.
Yeah, you couldn't. Yeah,
yes.
Yeah, that's correct. Okay,
yes.
Because this is a non-contrast scan. The standard is a contrast enhanced CT scan of the abdomen. In any case of trauma, if you have in the Fath scan any free fluid collection or something like this, please do the standard. But in this case, really, it is a challenging case. It's non-contrast. And where is the fluid collection? Can you give me precise location? You told me it is in the hepatorenal. Is it in the hepatorenal? It's localized in the adrenal gland.
Retroperitoneal, in the
retroperitoneal, correct? Okay.
Yes, in the right adrenal.
So this is at the site of the right adrenal gland. Okay.
Yes.
But maybe adrenal hematoma. You are right. Maybe adrenal gland injury. Okay. Can you go please more inferiorly?
Okay.
More down? Yeah. Here, please. Can you stop here?
Yes.
Around the kidneys.
Yes, I couldn't really separate the upper pool of the kidney from also this region, which could be also hematoma in the right upper pool, the kidney.
Where is this? Where is the location here? Can you give me precise location? More precise location? Yeah.
Just 1 second. I have to go up and down.
It's not really in the hepatorenal. Hepatorenal, it's clear.
Yes, this is in the retroperitoneal.
It is retroperitoneal. Totally agree.
Yes, in the right renal pouch.
Give me more location. What are the spaces in the retroperitoneum? Do you know?
Pre-renal and the pre-renal.
Perirenal. Yeah. Okay.
But it's not going to the retrorenal space.
Okay. If I go here, okay, this is the kidney cell. Okay. And around the kidney, we have some sort of hemorrhagic, hemorrhagic fluid in the perirenal space. Okay. So this is a perirenal space. Okay. Okay. And this is the pararenal space. We will describe this later on. And this is the posterior renal space. So this is a perirenal space. Okay. It's not pararenal, not anterior or posterior pararenal space. Okay. What else?
Just I will try to find if there is any other thing. In this retroperitoneal space, I want to be sure that there is nothing also in the duodenum or in the.
Okay.
Okay, the duodenum for me appear normal.
The duodenum is free. Okay.
Yes. I want to look also for the pancreas.
Okay. The pancreas is free.
Okay, I want to.
I'm helping you to save your time. Okay.
Okay.
But you are going very smooth and perfect.
Okay. Also in the retroperitoneal region, the ascending colon also appearing normal. So I think this is the main abnormality with this fat stranding also surrounding this collection. I couldn't really appreciate that.
Okay, can you go to the lower chest, please?
Okay. This is a lower chest also.
Okay.
With this effusion, which appear also to be slightly hyper intense.
Hyper tense. Okay. Just a minute, please. I will help you. I will give you the lung window, please.
Okay.
Okay. Okay.
Okay. Just I will have a look 1 second. Okay, there is evidence of left pneumothorax also noted. And bilateral ground glass opacity in both the lung parenchyma with this region in the left side.
Yeah.
This could be pulmonary hemorrhage also with or pulmonary contusion. With this thorax, I want also to look for the bone window to see if there is a fractures noted in the ribs or in the vertebrae.
Do you have any fractures?
I want to look for it in the bone window, but just
in this window, do you have any fractures?
Yes.
Okay.
Yes. There is
one of the dorsal vertebrae. Okay. What else in the lung window? You told me we have multifocal, poorly defined, ground glass patchy areas and consolidated patchy areas. Okay. What else?
I am trying to look for the left bronchi also. The left bronchi. Sorry, the right one. The right.
What is this area?
Yes, the right hilum and this right airlocules, because there is maybe bronchi fistula.
Bronchopleural fistula, maybe.
Yes.
But it's simply, what is this one? It's a linear.
Linear lucency.
Linear gas lucency.
Yes.
Okay, traversing the right lower lung loop.
Yes.
Okay, what is this one? What type of injury is this? This is lung laceration.
Yes.
Okay, this laceration may lead to bronchopleural fistula, maybe not. If we have this hemopleural effusion or hemopneumothorax on the right side, if we inserted tube and failed to evacuate the pneumothorax and hemothorax, so we can think for bronchopleural fistula. Okay, but at this stage, you can say we have a lung laceration or pulmonary laceration. Okay, so we have consolidative changes. This one indicates contusions of the lung, and we have lung lacerations, and we have one of the dorsal vertebrae shows fractures. Yeah, can we go to the? I will help you to see the sagittal.
Yes, I want
to sagittal. Just a minute. I will give you the bone window. Okay.
Yes.
We will not go in more details because it's a genitourinary session. But what do you have here?
Of posterior alignment and some bony fragments in the spinal canal, which may cause spinal cord impression, and this is an impression. Also, there is a fracture in the posterior.
You are right.
The posterior
you are right. You are right. We have like compression of the vertebrae and the fracture along the superior vertebral plates and going posterior to the posterior arch, and we have retropulsion with the posterior cortex inducing spinal canal stenosis, and this is simply chance fracture or cell-field fracture because it is a fracture involving the posterior arch and the vertebrae and the mix between compression or flexion and distraction. Anyway, we will not go in deep in this one, but let's again, I need to focus on the abdomen. Okay. And the abdomen here, we have perinephric hematoma extending to the adrenal gland region, maybe adrenal gland hematoma, as you said. and we have vertebral fractures, and we have lung injury as we described before. Okay, that's fine. Can we move to the next case? Okay, this case really, let us see this one. This case came to me complaining of abdominal pain. Can you scroll, please?
Abdominal pain.
Yes.
Okay, again, this is the CT abdomen, non-contrast. Just I will scroll down and then I will go back. Sorry, it's stopped.
Okay.
Okay. It's still loading. Just not responding for scrolling.
Go upward. Go upward. Okay. Yes. Okay.
Okay.
Yeah.
Okay.
No. Okay. Yeah. Scroll, please. Okay.
I can appreciate that there is evidence of large retroperitoneal low dense lesion noted in the left side of the abdomen, which appear to displace the left kidney slightly medially, and also displace the bowel lobes to the right side of the abdomen. This soft tissue density appear to be with low dense, which may be which suggests lipid content or fat content.
Okay. Scroll for you. Okay. I will scroll it for you. Okay. Can you give me the hand, please? Okay. Okay. So this is a mass in the left side of the abdomen, as you said. It shows predominant fatty attenuation.
Yes.
Okay. What else?
This it appears to be retroperitoneal, and there is some septation inside, and the fine of tissue component. Left kidney appear to be displaced.
Displaced. Okay.
Yes, and also the aorta.
It was superior, really.
Yes.
Okay.
Just I can appreciate also that there is
some. Can you give me more details about this mass? It's
for me, it's retroperitoneal.
Okay.
Which mainly would be liposarcoma.
It is displacing the small bowel, large bowel to the right side, displacing the aorta, IVC to the right side, displacing the kidney superiorly. Okay. And give me more details about the density. It shows, as you said, predominant fatty density. What else?
With some interseptations and soft tissue components also. Sorry, this is septations, internal septation and soft tissue component.
What are these lines? Septations, yeah. Okay.
Yes.
6 septations.
Yes.
Okay.
And also some of the soft tissue
and for a little bit internal.
Yes.
Soft tissue densities. Okay. Your sound is not clear. Can you give me diagnosis, please?
Liposarcoma. I'm thinking of liposarcoma. Liposarcoma.
Candidate number 1.
Yes, I'm here, doctor.
Yeah. I'm sorry. I have some technical problem. Okay. Can you give me final diagnosis in this case, please?
Liposarcoma. My
liposarcoma.
Diagnosis for this.
Yeah, it's a very huge mass, retroperitoneal mass, as you described. So it is liposarcoma. Really, this case was done on 2024. When I reviewed the old exams for this patient, I discovered this one. If you can see this one, okay.
Yes.
You will find here, this is the mass.
Yes.
And much smaller in size. So it is low-grade neoplasm. What type of liposarcoma here in this CT scan? Do you know the types of liposarcoma?
No.
Okay, we have 5 types of liposarcoma. We have well-differentiated liposarcoma. We have myxoid liposarcoma. We have dedifferentiated liposarcoma. We have pleomorphic liposarcoma, and we have mixed type. Okay, so this is a well-differentiated liposarcoma. Okay, because it's low grade and not metastasized. Okay, but really this well-differentiated liposarcoma may turn to other higher grades of liposarcoma with rapidly progressive
But I can appreciate
behavior.
low dense lesion in the spleen, in the
we have newly developed splenic cyst. This is splenic cyst, really. It's not metastatic.
Okay.
And the case really, the clinician requested to do MRCP. I don't know really at the time what is the indication, but what was the indication for this one? But this is the mass.
Okay.
And this is a splenic cyst. Okay. And in the fat suppressed, let us see the fat suppressed. Okay, it's almost suppressed.
Okay.
And we have these internal septations. We have soft tissue densities in between. So this is maybe high-grade liposarcoma. It's difficult to describe this one as a well-differentiated liposarcoma because of huge size and soft tissue densities and internal thick septations. Okay. Okay. Thank you so much, candidate number 1. Can we move to candidate number 2?
Yes, sir. Assalamu alaikum.
Yeah, candidate number 2. How are you?
Alhamdulillah. How are you, sir?
Alhamdulillah. Fine. Alhamdulillah. This patient, can you please send for me request for remote control?
Yeah, sure. I've requested.
Anyway, yeah, I would like to thank volunteer number 1 because you had some or 2 challenging cases at the beginning of our session. Thank you so much. Okay. Yeah, this patient came to me complaining of loin pain. You can move. Yeah, you can scroll.
Okay. I'm presented with CT scan axial sections, unenhanced study of a patient who presented with loin pain. As I'm going down, I can see that liver appears homogeneous.
Okay.
All right. I can see the left kidney is enlarged in size and has some hypodense area in the region of the renal pelvis. On the unenhanced study, I'm looking for any calculi. In the bilateral renal or ureter's location.
Okay. Can you move? Yeah. Can you move more superiorly? Yeah. In the pelvis, yes, the pelvis is free.
Pelvis is free. Okay. So I can see the bilateral kidneys show some hydronephrosis. However, I do not see any hyperdense calculi. There is some perinephric fat staining also noted.
Okay.
Hyperdense lesion. And I want to see the post-contrast images for further evaluation.
Really, the patient had renal impairment and we couldn't inject him IV contrast.
All right. So I will now look for the cause of the hydronephrosis. I will now like to trace the bilateral ureters. As I go down, I can see that there is a retroperitoneal soft tissue, or it could be lymph nodes. There is no high density or calcification seen within it. There is some soft tissue density noted in the aortocaval region at the level of L4, L5 vertebral bodies. These are suspicious for retroperitoneal fibrosis. I will like to correlate with the history of the patients. This could be related to the IgG4 disease. So I will like to correlate with the inflammatory markers and blood levels of the IgG4. I will also like to investigate the other causes of the retroperitoneal fibrosis, which could be due to any medication.
If it is retroperitoneal fibrosis, can I go more superiorly? Okay. If this one is soft tissue sheets, as you said, retroperitoneal soft tissue sheets, para-aortic and paracaval, and may raise possibility of retroperitoneal fibrosis. Retroperitoneal fibrosis, what are the causes for this retroperitoneal fibrosis, as you mentioned
It could
before?
be, yeah, it could be idiopathic in
It could
70%
be
of the
idiopathic.
cases.
Yeah, perfect. Yes, you are
Yeah.
right. Okay. And maybe
Other
secondary
causes,
for, yeah, secondary for what?
secondary to any medication or
Yeah,
any drug
drug
toxins.
toxicity. Okay,
Yeah.
very nice. What else?
Other causes could be due to any malignancy, such as
Yeah.
lymphoma.
Okay, very
Other
nice. Okay,
possibilities could be due to inflammation, such as
very nice.
pyelonephritis.
Perfect. Yeah. Okay. And maybe one of the presentation of IgG4, and if it is IgG4, what should you do to what? Yeah, what should you describe? Should do, or what should you describe here in this case?
I would like to see the other manifestations of the IgG4 related
Yeah,
disease,
you
which
are right.
could represent
Okay.
autoimmune pancreatitis or
Yes, we don't
any
have autoimmune pancreatitis. Yeah, very nice. Okay, what else?
other could be any cholangitis, autoimmune
Yeah, we
cholangitis,
don't
with
have
no
any cholangitis.
intrahepatic
Okay, sclerosing
perinephric
cholangitis.
dilation
Also,
seen.
sclerosing mesenteritis. Yeah,
Yeah,
we don't have any sclerosing mesenteritis. All of these are common associations
abdominal
of
manifestations
IgG4
of.
disease. Okay, how can we differentiate between acute and the chronic?
We can differentiate on the PET CT, because if it's active, it will be shown hyper. It will like have increased metabolic activity on PET, and if it is inactive, it will
Okay,
show low
very nice.
metabolic activity.
Okay, but how? Okay, it's a good idea. What else? We need more cheap method to differentiate between acute and chronic.
Acute and chronic on the CT scan, I don't know.
Not on the CT scan. Okay.
Okay.
What
Maybe
what
with
other
the
modalities?
What other modalities? MRI, maybe, to see the post-contrast enhancement. All right, and this is causing the bilateral
MRI.
hydronephrosis.
This is soft tissue sheets, retroperitoneal soft tissue sheets, entangling the post ureters and displaying dark signal on T2. Is it acute or chronic? Dark signal in T2.
Chronic. It represents
Chronic,
fibrosis.
yes. Yeah, chronic. It's fibrosis. It's mature fibrous tissue. Okay, so it's chronic retroperitoneal fibrosis. Okay, very nice. Let's go to the next case. Okay, just a minute. Okay, go ahead.
All right. So I'm presented with CT scan axial sections of abdomen, unenhanced study. First, I will like to go through the stack of the images, then I will start describing my findings. I can see that there is prominence of the left ureter. Left ureter is dilated. I am tracing it downwards. I can see that there is some soft tissue with calcific density seen on the left side.
Okay.
Yeah. After this soft tissue, the distal part is not dilated of the left ureter.
Okay.
This is the point of obstruction, I believe, with some soft tissue and calcific density
I think
within
this
it.
is a vascular calcifications. Okay.
Okay.
This is linear.
This is the dilated ureter.
Yeah,
now
this is
I
a
am
dilated
tracing
ureter.
it.
Okay.
Yeah, I am tracing it to look for the cause of its dilatation and the level of obstruction. As I go down, I can see that there is some hyper dense soft tissue seen within it, within the lumen, which is raising the possibility of any it has on unenhanced study, my differentials could be a blood clot, Other possibility could be of any mass lesion, such as TCC.
Really, I couldn't hear you perfectly. I don't know why.
Can you hear me now?
May I have some technical problems?
Just 1 minute. I'll change my headphones. Can you hear me now?
Yes, I can hear you. Okay, go ahead.
Okay. As I was tracing the dilated left ureter,
Yeah.
I can see that there is some area of hyperdensity noted within its lumen. This could represent any blood clot, or this could represent any mass lesion such as transitional cell carcinoma. Other possibility, less likely, could be
Okay,
of a
I agree with you that is the lower ureteric segment. There is a discrepancy between there is a discrepancy between the upper. There is a discrepancy between the upper ureter and the lower ureter.
Yeah.
And yeah, you are right. We have something like ureteric stricture or something like this. I totally agree with you. Okay, really, I report this one like as you said. But do you have any other abnormalities?
Okay. The bilateral seminal vesicles are normal. Prostate shows some calcifications, but the size is normal. As I go up to spot for any other abnormality. Some I think there is some periodic lymphadenopathy maybe.
Yes, you are right.
And yeah, because the fat planes between the aorta and IVC here, I can see some soft tissue within it. In my routine practice, I would like to see the sagittal reformate images also for further confirmation and to look at the status of the adjacent vertebras. Yeah, this is enlarged lymph nodes at the level of the left renal hilum.
Perfect. Okay.
And I will like to see the post-contrast images if available for further evaluation, or otherwise MRI.
Yeah. Really, I just give me the hand, please. We have this case is the clinician requested to do CT urinary tract searching for any stones. Really, we didn't find any stones, but as you said, we have dilatation of the left ureter and left pelvic system, and this dilatation surrounded by periureteric fat stranding. And here we have sudden discrepancy between the lower ureteric segment and the middle ureteric segment. Okay.
Yeah.
And this one can represent ureteric stricture. Really, we requested to do CT post-contrast CT urography. Okay. To evaluate this segment, but really we didn't. Yeah, this point is don't be saturated and perfect. You were not saturated by these abnormalities. We have multiple retroperitoneal lymphadenopathy, para-aortic. Okay. What are the causes for this? Yeah, if you have any case with retroperitoneal lymphadenopathy, what are the causes? How can you search for any other?
If we have periodic lymphadenopathy in a male patient, then we would like to see the status of testes.
Yes, you're right. Testes, okay, one of the hidden areas. Okay. Yeah. Really, I go here, but really we didn't cover the testes, really, unfortunately. Okay. But okay, it's one of the hidden areas. What else?
Other possibility could be of lymphoma.
Lymphoma, okay, maybe. Okay, what else?
Yeah. Other possibilities could be of any infection.
Yes, very nice. Okay, we have infectious causes. We have neoplastic causes. Okay, neoplastic causes may be metastatic, maybe lymphoma, metastatic from the testis. What else? If we have female patient, what are the primary causes?
In a female patient, then this could be related to any ovarian pathology.
Okay.
Or
also choriocarcinoma. Okay.
Yeah.
Okay. Endometrial carcinoma, choriocarcinoma. Okay. All of these. We have also colorectal carcinomas. We should search prostatic carcinomas. You should search. Yeah. All of these can present by retroperitoneal metastatic lymph nodes. How can we narrow our differential diagnosis in this case?
We'll like to
This is a
correlate with,
metastatic lymphadenopathy.
yeah, the nodes appears pathological. They are enlarged and rounded.
Yeah. How can we narrow our differential diagnosis?
We will like to correlate with the history of the patient and also with the blood or inflammatory blood markers, inflammatory markers, any previous images if available. Okay, on the bone window, I want to see the status of the bones to look for any lytic or sclerotic lesion. As I'm looking at the bones, I can see that there is a lytic destructive lesion seen at the L5 vertebral body.
Okay, very nice. We have L5.
With the destruction of the cortex posteriorly.
Yeah, okay.
Yeah, I want to see the sagittal sections also to look for the multiplicity of the lesions.
Okay. Anyway, we need to save your time. We have multiple lytic and sclerotic lesions.
Sclerotic lesions, yeah.
And this case proved to be prostatic carcinoma.
Metastatic, yeah.
Yeah, old age with sclerotic osseous lesions. This case was proved later on as a prostatic carcinoma. Okay. Okay. Thank you so much. With right loin pain.
Yeah.
And the CT urinary tract was requested by the physician.
Yeah. So I'm trying to scroll now the images. I'm presented by axial non-contrast CT scan of the abdomen and the pelvis for patient complaining of right loin pain. I'm scrolling down now in the pelvic region. I think the pelvis is unremarkable, so I will go again from up downwards through the images. From the first look, I could see there is evidence of right-sided hydronephrosis with dilatation of the right ureter. I'm trying to trace the dilated right ureter downwards.
Okay, very nice.
Yeah. Here there is a cut off of the dilatation of the right ureter. I couldn't elicit the right ureter at this level. However, I couldn't see any soft tissue mass lesion or dense stone in this area. While I'm tracing now, I can see there is curving of the right ureter posterior to the IVC. I'm thinking now in other possibilities like Retro-caval ureter. While I'm still scrolling down through the images to see if there is any abnormalities in the pelvic region.
Okay, what's your next step?
Yes, my next step, I will check in the post-contrast study and the coronary images as well to confirm the findings and
okay, give me the hand, please. Okay.
Yeah.
We did for this case post-contrast CT urography. Can you please scroll? This one was done in prone position. Okay.
Yeah.
Okay. Go ahead.
So this is the same patient with CT urography. I'm scrolling down through the images. There is fullness of the pelvic cell system at the right side, as I traced already in the non-contrast study. However, I am still tracing the right dilated right ureter compared also to the left ureter.
Right ureter.
Yes, compared to the left ureter, there is
compared to the left ureter,
at the right side, and here this region
very nice, perfect,
of interest. At this region of cutoff, I can see there is contrast seen behind the IVC. And
Okay.
the ureter after this point becomes same caliber like the left side. So
Yeah.
this is confirming the
Very nice. Perfect.
suspicion of
You are perfect
retrocaval.
candidate number 3. Okay, so you have here, we have moderate to marked hydronephrotic changes. We have dilated ureter, and this dilated ureter curving here or encircling or moving posterior to the IVC, making complete loop around the IVC. So this one is called retrocaval or circumcaval ureter. I like circumcaval ureter more. Okay.
Yeah.
And if you here in the 3D image.
Yes. This is
here in this 3D image, you will see the looping of the right ureter. So this case of circumcaval right ureter. Very nice. What type of this one? We have two types of circumcaval ureter.
Really, I don't know.
Yeah, this is type 1. Okay, we have two types. If we have secondary hydronephrosis, this one is called type 1. This is the most common. The second type.
Yes, I will try to scroll through this image.
Okay.
So this also
this trauma case. Okay.
Non-contrast CT study of patient came in trauma.
Okay.
I am scrolling through the whole images first before start to comment on the presented scan. Yes, here in the pelvis. So what I can see from the first images, there is evidence of smudging of the left-sided subcutaneous fat with large soft tissue seen along the left iliopsoas muscle with bulkiness of the left iliopsoas muscle until the pelvic region. In my routine practice, I will check the whole images because this is trauma patient. I can see if there is any evidence of fracture. The right side showing comminuted fracture at the right iliac and femoral, right femur and right iliac bone.
Where is this fracture?
The right femoral.
Yes, the right femoral head. We have hip replacement.
Yes, as
on the
maybe
right
this
side.
is making the artifact for
making
the
a beam
images.
hardening artifacts. Okay,
yes,
very nice. Okay, let's concentrate or let's focus on this area, please. Yeah.
Yes.
Can you give me more details?
Yes, there is.
You told me that the left iliopsoas muscle is markedly swollen. Okay.
Yeah. It is markedly swollen, and also there is the anterior displacement of the left kidney and perinephric fat at this region. There is also smudging of the fat balance at the posterior abdominal wall muscles. I will put the possibility of psoas hematoma, psoas muscle hematoma as a first possibility for this case, and I would like to check the coronal images to see obviously the extension of this hematoma as it makes displacement of the retroperitoneal structures, the kidney and the perinephric fat, and also I can confirm
what's your next step? Okay, what's your next step?
Contrast enhanced
perfect
study.
Okay.
Yes,
you are right. Okay. Anyway, give me the hand, please, to describe this one in more details. This is a case of trauma case. And by the way, we have many vascular calcifications. Don't diagnose this one for a stone, for example, because it's linear and going with the renal vessels. So those are not stones, those are vascular calcifications. Let's focus in this area. We have left psoas muscle intramuscular hematoma. It's hyperdense. Okay. And also we have some other hematomas. But before going to the other hematomas, please, can we please can I give you some details regarding the retroperitoneal species? Okay, we have here, what is this area? What is this line?
anterior para-renal space.
This is anterior renal fascia, gyrotous fascia. Okay, okay. And what is this line?
Posterior renal fascia.
Posterior renal fascia. Zuckerkandl's fascia. Okay, okay. And what is this line? Lateral conal fascia. Okay, okay. So, what is this area? This area is anterior pararenal space. What is this area? Posterior pararenal space. Okay. What is this area? What is this area? This is perinephric space. So we have perinephric space surrounded by anterior renal fascia and posterior renal fascia, and we have anterior pararenal space, and we have posterior pararenal space. Okay, and we have here, if we remove this one, look for this one. This is lateral conal fascia, and it is thickened and expanded by fluid. Posterior renal fascia, it is thickened and expanded by fluid. Okay, and this hematoma is localized in the psoas muscle and posterior pararenal space. Okay, look for this hematoma. Look for this hematoma. Look for this hematoma. All of these are located in the posterior pararenal space. Okay, we have central part of the retroperitoneum. It's almost free, but the hematoma is localized in the left psoas muscle and posterior pararenal space. Okay, if you have any case of retroperitoneal hematoma or perinephric hematoma, contrast enhanced CT scan is recommended to assess the integrity of the renal vessels and to assess possibility of active extravasation. Okay.
Yes.
Okay. Thank you so much. Candidate number. You are candidate number 3. Okay.
Three.
Okay. Can we move to candidate number 4? Candidate number 4. Walaikum salam. How are you?
Yes, sir. I'm good. How are you?
Alhamdulillah, fine. Alhamdulillah. Let's move to next case. Okay. Candidate number 4. Yes.
Yes, sir.
Can you please describe?
Okay. Yes, sir. This is a frontal radiograph of the abdomen in which I can appreciate that there is air outlining the lateral margin of left psoas muscle and the renal margin and upper pole. I can also appreciate a similar air lucency noted along the lateral border of the right psoas muscle as well. I can also
Very
appreciate
nice.
ileostomy bag along the
Very nice.
right iliac fossa.
Okay.
And next, I would like to look at the CT images to look for the cause of this retroperitoneal pneumoperitoneum.
Okay, so you have an evidence of retro-pneumoperitoneum. Okay,
Yes, sir.
as you said, yeah, we have gas lucency here in the suprarenal region and going along the psoas.
Lateral border of the psoas shadow,
yeah,
yes.
And here, all of these are retroperitoneal, retro-pneumoperitoneum, and we have ileostomy bag. Okay, and this is the X-ray erect for the same patient.
Okay.
Can you see anything else? Yeah.
Yes, sir. This air lucency is tracking along the upper aspect, and it is also seen just below the right hemidiaphragm, and it is also giving a continuous diaphragm sign. And yes, so it is suggestive of retro-pneumoperitoneum as well as the pneumoperitoneum.
Yeah, very, very nice. We have mix between retro-pneumoperitoneum and the pneumoperitoneum. Okay, this one is air under the bed. Okay, what are the possibilities?
Sir, the possibilities include, sir, for pneumoperitoneum, most likely it can be due to perforation of any hollow viscus.
Let's focus in the retro-pneumoperitoneum. Okay.
Yes, sir. It can be due to, sir, emphysematous it was not seen within the pelvic calyceal system. So yes, it can be due to any perforation of the retroperitoneal organ, such as perforation of ascending or descending colon.
Very nice. Okay.
And also, yes, only the first part of the duodenum is intraperitoneal. The rest of the duodenum is also retroperitoneal. So it can
so
be
second and third parts of the duodenum, ascending and descending colon. What else?
Sir, other can be sir, along the
rectum.
Yes, sir. Rectum. Okay.
Okay. Okay, so we have the possibility of perforating viscous or diverticulitis, perforating diverticulitis in the ascending colon, descending colon, maybe rectum, maybe second or third part of duodenum. Okay, what else?
Yes. Sir, any
we have ileostomy bag.
Yes. It can be due to any
operation.
Yes, sir.
As you said,
okay.
maybe
surgical, yes.
This case underwent right hemicolectomy with ileostomy bag. Okay. So this one considered one of the causes, iatrogenic causes. Okay, what else?
Okay. Sir, it can be due to iatrogenic causes and
iatrogenic, perforating viscous, ruptured diverticulum or diverticulitis, abdominal trauma,
and peptic ulcer disease, but that would be more
pneumoperitoneum.
Yes, pneumoperitoneum.
Oh,
but if there is any yes, if there is any ulcer beyond the first part of duodenum, that can also lead to retroperitoneal layer.
We finish this part. Okay. What else?
Yes.
Abdominal trauma, infection, maybe also extension from pneumomediastinum. Okay.
Okay. Yes.
Okay. Let's move to this case, please. This case, this case.
Sir, I cannot see the full image. Okay, now I can see.
Okay. This case, I will scroll for you. Okay, to save your time.
Okay.
This case was presenting by loin pain and diabetes insipidus.
And diabetes?
Diabetes insipidus.
Okay, diabetes insipidus. Okay, these are these are axial images of the CT abdomen and the portal venous phase, in which I can appreciate that bilateral kidneys show moderate hydronephroureter. And I can also appreciate fat stranding along bilateral kidneys in the perirenal space. And okay, now I'm looking for the adrenal glands also above. Yeah, the adrenal glands appear unremarkable. And there is, yes, I would like to trace the ureters.
Ureters are free.
Ureters are unremarkable. Yeah.
Yeah.
Okay. I'm also looking for yeah. Okay, so the differential for this appearance could be due to lymphoma, perirenal lymphoma can present like this. And other differential could be due to Erdheim-Chester disease that is giving hairy kidney appearance. And other differential.
Very nice.
Okay, it can be post-infectious, but it is rare bilaterally that to present like this.
It's not logic. Yeah. Okay.
Yeah. Okay.
What else?
And what else?
How can we narrow our differential diagnosis? How can we reach our diagnosis?
Okay, for that, I would, as I cannot appreciate any abdominal lymphadenopathy, marked abdominal lymphadenopathy, so I would be thinking more on the line of Erdheim-Chester disease. And for that, I would also like to look at the bone window. And
very nice. Very nice. Okay.
Okay. Yes. In the bones, I can appreciate that there are multiple lytic and some sclerotic lesions as well.
Yes. Yes.
So these are in keeping with the Erdheim-Chester disease.
Yeah. Very
And
nice.
in this, I can also correlate with the X-ray of the long bones,
Very
because
nice.
Erdheim-Chester
Searching
present with
for
diaphyseal sclerosis.
Diaphyseal and metaphyseal sclerosis. Okay, not only
Yes.
diaphyseal. So this one
Yes.
is a case of Erdheim-Chester disease, as you said. And Erdheim-Chester disease, it's non-Langerhans histiocytosis and can affect
Histiocytosis.
many organs. Yeah, it can cause hair-like infiltrations, perinephric soft tissue infiltrations, as you can see here, and causing some entrapment of the both ureters, causing hydronephrosis on both sides. Also, it can affect many organs, can affect the bones. Skeletal involvement is in 90%, more than 90%. Diaphyseal metaphyseal sclerosis, as you said. Also, it can affect the infundibulum of the pituitary gland, which can
cause
explain diabetes.
diabetes insipidus.
You
Yes.
are right. Also, it can affect the lungs. I think we discussed one of our cases in cystic lung diseases, Erdheim-Chester. It can cause cystic lung diseases and interstitial pulmonary edema. Okay, very nice. Thank you so much, candidate number 4. Can we move to candidate number 5?
Thank you, sir.
Thank you so much.
Good evening, sir.
Candidate number 5, how are you?
Yes, sir. Good evening. Yeah, good. Sir.
Okay. I will scroll you to save your time. If you want to scroll, okay, no problem. Okay, I will give you the hand. Okay, you can scroll from here.
Okay, sir. I'll start from the beginning. This is a contrast enhanced CT abdomen. So, okay, I can see there is a soft tissue mass in the retroperitoneal region.
Yeah.
It shows heterogeneous enhancement.
Okay.
And cyst is seen in the left renal kidney. Okay, this mass is displacing the vessels anteriorly, especially the IVC. And also pushing right renal artery anteriorly.
Okay.
Okay, one simple cyst seen in the right
Can you
kidney.
please raise your voice, please?
Yeah.
Okay, so we have a retroperitoneal mass, as you said, showing a heterogeneous enhancement and necrotic core, and this mass is invading the IVC, the infrahepatic portion of the IVC. Okay, do you agree?
Yeah. Yes,
okay. Sir. Yeah. Okay, and it's I think it's abutting the right diaphragmatic crust, as you can see here. Yeah. Okay. Okay. So what's your differential diagnosis in this case? We don't have any other abnormalities. What's your differential diagnosis?
So it could be a mass of the lymph nodes, as it could be the amalgamated lymph nodes.
Okay.
But as its invasion is there, so it is look like malignant.
Okay.
Malignant lesion, and but this adrenal gland is appear unremarkable, and kidneys are also normal. So
okay.
It could be in I think in the retroperitoneal region, malignant lesion.
Yeah.
Yeah. So here origin I cannot assess because the adrenal is normal, and it could be related to the from the diaphragm or soft tissue mass, because it's closely abutting the right crest of the diaphragm.
Okay.
Or any vascular origin, I'm not sure, but it could be any vascular origin if it's invading IVC.
If it is vascular origin, what type of tumor this one?
Sir, angiosarcoma can be, but it's that address.
It's okay. If it is vascular in origin, let us finish this case. Can you give me the hand, please? We have this mass is a retroperitoneal mass with intravascular and extravascular components. Okay, we have two different components.
Yes.
Inside the IVC and outside the IVC. We have two possibilities. Either it's arising from the IVC and going outside. So this is a case of leiomyosarcoma, and The second possibility may be retroperitoneal sarcoma, like undifferentiated polymorphic sarcoma, for example, or the initial name is malignant fibrous histotoma and invading the IBC. So we have two different possibilities. As you said, you are perfect. We have a malignant mass, retroperitoneal mass, invading the IBC or arising from the IBC and going into the retroperitoneal space. And this case was proved to be IBC leiomyosarcoma. So we have three types of retroperitoneal sarcomas. We have liposarcoma, leiomyosarcoma, undifferentiated polymorphic sarcoma, or malignant fibrous histotoma. This is the same name. Okay. Leiomyosarcoma, if you have any retroperitoneal mass arising from any major vascular structures, example, from the IBC, you should search for leiomyosarcoma. Okay? Okay. Let's go to the next case, please. Last case for you. Okay. You can scroll if you want.
Yeah. I'll go from the start.
Yeah.
Okay, so there is a left-sided pleural effusion with vessel consolidation. So there is a large soft tissue density in the retroperitoneal region, which is displacing the aorta anteriorly.
Yes.
And there's soft tissue also encasing the vessels like renal arteries.
Yes.
And also around the aorta. So I gone down. So this soft tissue density extending up to the pelvis and also involving the right-sided pelvic vessels.
Okay.
So for me, for the main first diagnosis would be this mesenteric lymphoma because it's encasing the vessels, but it's not causing narrowing of vessels.
Very
And,
nice. Okay.
So, and beside that, some soft fat straining seen around the left kidney. So
Okay.
this could be due to the compression of ureter.
Yes.
Or,
Okay. Very
otherwise,
nice.
no
Very
failure
nice. Very
in
nice.
the pelvic
Okay.
region.
So this case, okay, let's summarize. What did you say? We have retroperitoneal masses, para-aortic, paracaval or aortocaval. We have also mesenteric lymph nodes encasing the mesenteric vessels. These retroperitoneal masses are encasing and compressing the left renal vessels and stretching the left renal vessels without any vascular obstruction. We have also these masses encasing the ureters without any obstruction. So also the aorta is displaced anteriorly, what we call the floating aorta sign. And also we have these masses encasing the vessels sandwich sign. So both of these signs are pathognomonic for lymphoma. Also the lymphomatous infiltration extending into the pelvis. What is this plane? Do you know the name of this plane? This plane, yeah. What is the name of this plane? This one. Let us see. I don't know. This one. What is the name of this plane? Okay. This one.
Okay, so I think it's in the pelvis plane. I don't know, sir.
This one is called combined interfascial plane. This is a combination between the anterior renal fascia and the posterior renal fascia that we described before. And by the end of this session, I will give you some tips. What are the names of these planes? What are the spaces of the retroperitoneum? We will focus on this. Okay. Okay. Anyway, in this case of lymphoma, and in case of lymphoma, you should review the bone. We have also osseous involvement here. You will find like diffuse sclerosis with some sclerotic patches. So there is lymphomatous infiltration also in the bone. There is bone involvement. Okay, this is a case of lymphoma. Okay, thank you so much. And we did for him ultrasound. Can you please scroll?
Been presented with axial CT abdomen images, CTKUB images, non-contrast study of a patient who presented with severe right iliac fossa pain. Would like to scroll the images from the top to the bottom before describing the findings further. So I would just scroll simultaneously noting any significant abnormality. There is an obliteration of the retroperitoneal fat on the right side with the low attenuation collection noted extending from the inseparable from the posterior renal cortex and extending into the adjacent posterior paraspinal musculature. It has the low attenuation foci within it, which is likely in keeping with air as the fat attenuation is different at this level. It is extending lower down into the psoas muscles and with having a multiloculated, multiseptated appearance extending partly into the retroperitoneum as well, having a thick multilobulated appearance and is continuing. I would like to trace its distal extent. It is continuing up till the iliacus muscle lowermost extent, and there is a significant lymphadenopathy noted along the inguinal region distally, and there is a altered soft tissue, altered muscular contour noted as well. In my routine practice, I would like to see it in the post-contrast enhanced images to further.
Really, yeah, perfect. First comment for you. You did a very nice prescription. You told me that we have an irregular cystic collection centered upon the right iliopsoas muscle with gas locules and air fluid levels. And also we have something like anterior extension for this mass. Let's play in the window here. We have like extra muscular component here projecting anteriorly, maybe retroperitoneal, maybe peritoneal component. We are not sure because this one is non-contrast, but for me, it is displacing the ascending column here anteriorly, maybe retroperitoneal extension as well. But before going to the contrast enhanced CT scan, I would like to ask you, because when this patient came to the ER, he is 26 years old and he's complaining of right iliac fossa pain, acute pain. And when we did ultrasound, we found this cystic mass, and the patient was not prepared at that time to do contrast enhanced study. But let me ask you, can you give me any opinion, any idea about this mass?
So this cystic mass with internal air foci is likely suggestive of an abscess. It's an inflammatory
Abscess,
infective collection.
Okay, once you have abscess like this one, how can we pick up or how can we get the cause for this abscess? What do you think is the causes for this abscess? What do you think?
So the causes in this case can be, it can be tracking down from the kidneys, extension from renal abscess, or it can be a tuberculous. It can be a tuberculous iliopsoas abscess, but in that case, there will be some calcification within it and some bony abnormality will be noted as well. Another possibility can be appendicular perforation in phlegmon, but in that case, there will be a predominantly intraperitoneal
You are
component,
a superhero. Really fantastic. You told me, we have, once we have abscess like this one, we should think for three main causes. Maybe direct extension, and this direct extension may be from the renal, maybe from osteomyelitis of the spine, also maybe hematogenous spread, maybe post-surgery or post-traumatic, surgery or trauma. If we have direct extension, we should think for, as we said, from the vertebral osteomyelitis. We don't have any vertebral osteomyelitis. We don't have any renal affection. Maybe appendicular. Also, we should think maybe appendicular, maybe diverticulitis, maybe Crohn's disease, something like this. Okay, very nice. Can you give me any clue to get our diagnosis?
So there is a obliteration of the posterior renal fat pad. It is in my opinion, it will be most likely from the renal extension because it has an obliteration of the
kidney. Is the kidney almost normal? We don't have any renal affection in this case. Even the ultrasound of the kidneys are normal.
Okay. So can I see the bone windows?
The bone window are clear. Yeah, very nice. Okay, the bone window, the bones are clear.
So I would like to see the lung window images to look for any tuberculosis.
Okay.
So there are multiple train-wide opacities and centrilobular nodules noted in bilateral lung lobes, more on the right side in the anterior lobe, some cavitation, some fissural thickening, in keeping with the endobronchial subtype of the infection, which is likely tuberculosis.
Very nice. Really, when we started to review the lung basis, we started to find 3 embodied infiltrates. We complete the lung scan. We found multiple cavitary lesions, innumerable cavitary lesions, multiple 3 embodied infiltrates, and this case was proved later on to be tuberculosis infection. Okay. I will give you another scan for the same patient. Okay. Look for this one. This is CT scan for the same patient after starting to drain the abscess. Okay. Can you please scroll and give me your comment?
Okay, so being presented with the axial contrast enhanced CT images after treatment, after drainage for the same patient. Would like to scroll the images from the top to the bottom before describing the findings. So the kidneys are totally normal. There is, I'm trying to look for any retroperitoneal lymphadenopathy, which is not there. There is still a phlegmon and a thickening is noted. There are some calcified, there is a pigtail catheter noted in the iliopsoas region with an adjacent to phlegmon. However, the air foci have resolved, the significant size is decreased, and there is no evidence. Some bowel thickening is observed and some dilated bowel loops are noted. And there is, so I've been trying to look for any intra-abdominal complication like extension into the peritoneal cavity. So for that, I would like to see the peritoneal reflections for any thickening along the peritoneum. There is some peritoneal thickening noted at this region here. But
this one, I think this one is layers. This one is inside the psoas muscle. And this one is a residual abscess within the inserted drainage tube. But I would like to ask you straightforward, what is this structure? What do you think? This one.
So just I would like to scroll it. This is the appendix. It is in continuous with the cecum. It is appendicitis secondary to the
Yes. It's appendicular inflammatory process, severe inflammatory process involving the appendix. Look for the sagittal plane. Look for the appendix. Here is the appendix.
Yes, there is appendix there.
Yeah, this one, most probably this one is appendicular tuberculosis infection with secondary psoas muscle abscess, called abscess, tuberculosis infection, most likely, because we have severe tuberculosis infection involving the appendix. Okay. Really, you are perfect, fantastic, candidate number 1. Can we shift to the next candidate, please? Candidate number 2. Thank you so much, candidate number 1. Candidate number 2, how are you?
I'm fine, alhamdulillah. Thank you, doctor.
Okay, let's go more. Okay. This patient, let's review this case. Can you see my scan?
Yes.
My study?
Yes.
Okay, can you request for remote control?
Okay.
And to discuss this case with me, please. Okay. This patient came to the ER as well, complaining of left side acute loin pain. And we did CT scan to searching for any ureteric stones or something like this.
Okay. This is axial cut CT for abdomen without contrast. I will have a scroll and then I will comment. I can see that there is bilateral pleural effusion noted while I'm going down, I can appreciate that there is evidence of fat stranding surrounding the left kidney, and there is maybe some collections with some stones noted within it. Just I will go down to the end, and then I will go back to the area of interest. I can appreciate that. Okay. Okay. I will go back. The urinary bladder appears to be slightly compressed as there is no too much urine within it. Just I will go back again for the left kidney.
Okay.
Okay. As this is without contrast, I can appreciate that there is a multiple calcified stones, calcified spots noted within it. Mostly it appear to be stones. However,
Okay.
there is evidence of marked fat stranding surrounding in the retrorenal and pararenal space.
Yeah, perfect.
And there is evidence also of low density of collection noted surrounding
Yeah,
the.
very nice. Very nice. Can I please, can you give me the hand, please? Can we adjust the window more? Okay. Okay. Go on.
Okay. Just yet with this multiple stones, I couldn't really appreciate that there is evidence of hydroureter or hydronephrosis noted.
Okay. Okay.
Yes, okay. No hydroureter clear or no hydronephrosis. So
Okay.
this could be this collection could be urinoma due to rupture pelvic calcium system, maybe from this stone
Perfect.
the kidney.
Yes.
This fat stranding could be obstructive, post-obstructive uropathy.
Okay.
Just if there is any post-contrast study for this, just for confirmation.
Okay. If you, what's your other differential diagnosis? Maybe urinoma. Okay.
Infection.
Agree. Totally agree.
Could be
infection.
Also post uropathy.
Perinephric abscess.
Yes.
Is that correct?
Yes.
Okay.
Yes.
What else?
It could be maybe. I don't know, but it would be mainly it would be post-obstructive uropathy.
If it is post as well or
yes,
post-intervention, what?
It could be also infection post as well.
Okay, infection. We have urinoma infection. What else?
I'm not sure really. What
hematoma.
Yes, it could be
hematoma. Perinephric hematoma. Yes. Yeah, okay. Those are the top differential diagnosis for this case. Okay, what do you have? Can you give me more findings in this case?
Okay, just I will have to start looking for all the other organs in the abdomen.
Okay.
Okay, I will start with the liver. The liver appearing normal.
Ignore the liver. Okay. Can you please focus on the urinary system itself?
Okay.
Yeah. I'm doing that to save your time. Okay. To allow us to see or to review many cases. Okay.
Okay. Just 1 second. I wanted to follow the ureter also, the left ureter. Okay.
The ureter is mildly dilated.
Yes.
But we don't have any stones, as you said. Okay.
Yes. I will go down to look for the urinary bladder. Okay. The urinary bladder also has a thick wall.
Okay, relatively thick wall.
But maybe because it's not completely full.
It's not. Yes, it's not distended.
Also, I can appreciate that there is evidence of hypodense collection noted within the aspect of the prostate.
Yes.
Could be
localized at the peripheral zone, left peripheral zone of the prostate.
Left of the prostate gland.
Yes. Okay. If you want to ask the clinician one question, what should you ask?
I want to know if there is any. I want to know if there is any fever for this patient.
Yes.
If this patient comes fever, because
correct.
Maybe also.
Yes, we have a fever. Yeah.
Abscess. Okay, this could be collection and abscess in the prostate.
Yeah. Okay. Well done. Okay. So once we have any perinephric collection, because this one is perinephric, not subcapsular, because it's not indenting the renal parenchyma. It's irregular in shape, encircling the kidney. I know it's hard to differentiate, especially in non-contrast study, but it's irregular. It's going to the perinephric space. And also, let's review some important points. If we have any perinephric collection and suspicious for perinephric abscess, can you give me the source of infection? What is the causes for this perinephric? If it is perinephric abscess, what are the causes? for this perinephric abscess?
It could be hematogenous spread from
Yeah, very
any
nice.
related
Hematogenous,
organ.
maybe, but more commonly before hematogenous.
It could be from, it could be also TB infection. It could be
Maybe direct spread from
yes,
which
direct spread.
organ?
Maybe as a descending colon in the
Yes,
left kidney.
direct spread. No. Direct spread from the kidney itself.
Yes.
From renal abscess, perinephritis, or something like this.
Yes.
Sometimes from urine reflux from the bladder and the prostate. And this case, we have something like prostatic abscess as well. Maybe prostatic abscess with urine reflux making or inducing perinephritis and complicated with perinephric abscess. All of these are many possibilities. Also hematogenous spread, you are right. Maybe also post as well, or post-traumatic hematoma or infected hematoma converted to be perinephric abscess. Those are many causes for these perinephric collections. Okay, well done. Just I would like to review the spaces for the retroperitoneum, because this case is very nice to review the planes. We have here, this is the anterior renal fascia, Gerota fascia. And this one is posterior renal fascia, Zuckerkandel fascia. And this one is lateral conal fascia. Okay. This space is perinephric space. And this space, let's take this one, it's posterior pararenal space. Posterior pararenal space, it is bounded by posterior renal fascia anteriorly and lateral conal fascia laterally and fascia transversalis posteriorly. Okay, and the anterior pararenal space at this area, it is bounded posteriorly by the anterior renal fascia, Gerota fascia, and bounded anteriorly by the posterior parietal layer of the peritoneum. Okay. Also, if you find this one is the anterior fascia and this is the posterior fascia, if we scroll down, you will find this anterior fascia and this posterior fascia converging and united together to form common interfascial planes. Okay, look for this plane, this area. In front of this plane, peritoneal structures. Behind these planes is retroperitoneal structures. Okay, this is a common interfascial plane. Also, I would like to add something very important, that these planes or anterior and posterior renal fascia, it's not one layer, it is multiple layers, multilaminated. When we have something like infectious process or inflammatory process, these layers can be expanded to be multiple layers and making this plane, if it is expanded, this one is called retromesenteric plane, and the posterior fascia, if it is expanded, it's called retrorenal plane, and this one, if it is expanded, we can call it lateral conal plane. This is site of the trifurcation of the fascia, of these fascial planes. Okay, I think it's that.
Yeah. Okay. Now I'm going down. Okay. A cystic lesion is seen in the left inguinal region or left femoral region. Likely a could be a lymph node.
So we have left perinephric soft tissue sheets.
Soft tissue, yeah.
Yeah, soft tissue sheets.
Yes.
Encircling the left kidney. Okay.
Yes.
Do you have any
and
more?
Also,
yeah.
Thickening or causing thickening of the interior Girota's fascia and the posterior Zuckerkandel fascia, and thickening of the lateral conal fascia. Yeah. In my routine practice, I will like to see the corneal images to look for.
What's your differential diagnosis in this case, please?
Okay. In this case, I'm thinking it's a soft tissue encircling the kidney and appears to be the enhancement is it is an enhancing soft tissue. So yeah, so it could be any perinephric hematoma. I would like to see it on unenhanced study as well.
I didn't hear you well, please. Can you please repeat again? What's your differential diagnosis in this case?
Yeah, it could be perinephric hematoma, but I will like to see
Hematoma,
the
okay.
unenhanced
Very nice.
images as well.
Okay, okay, very nice. You should review the non-contrast study
Yeah,
to check is it
non-contrast
perinephric
study. Yeah,
hematoma or not. Okay, very
yes,
nice.
yes.
Okay, what else?
Other possibilities could be of lymphoma, but that would be
Lymphoma.
low attenuation.
Okay, maybe. How can we check? How can we confirm? How can we exclude lymphoma or rule out lymphoma or confirm lymphoma?
By looking at any other lymph nodes.
Now, okay, yes. Do you have any other lymph nodes?
Okay, now I'm looking for any para-aortic lymph nodes.
Let's help you because to save your time, please.
There is also, I would like to see the bone window also.
Can you check Retro-caval lymph node group, please?
Yes, I can see that there are multiple enlarged retrocaval lymph nodes enhancing.
Yeah. So your differential diagnosis may be perinephric hematoma, okay, perinephric collections, but it's not matching with perinephric collections or abscess or something like this. But the perinephric soft tissue sheets, enhancing soft tissue sheets, may be perinephric lymphoma, and we have also retroperitoneal discrete enlarged lymph nodes, as we saw together. So renal lymphoma should be considered, and it was proved as renal lymphoma. Can you please tell me what are the different patterns of renal lymphoma?
Renal lymphoma can present as hypodensities in the renal parenchyma, multiple hypodense nodules. It could also represent as the perinephric low attenuation encasing the bilateral kidneys or unilateral kidney. Yeah, other possibilities could be of a mass lesion which is conforming the contour, not deforming the contour of the kidneys.
So lymphoma can present by single mass or multiple masses, multiple bilateral masses, maybe perinephric soft tissue sheets like this one, maybe also diffuse infiltration of the renal parenchyma. And this, it's very common in Burkitt lymphoma. Also, sometimes invasion from the retroperitoneal lymph nodes towards the kidneys. Okay. Thank you so much. Can you please keep with me? Can we go to the next case, please? Okay, go ahead.
All right. So I'm presented with CT scan axial sections of abdomen post-contrast images. First, I will like to scroll. Okay. As I'm scrolling, I can see that there is mildly enlarged prostate noted with with invagination of the median lobe into the urinary bladder. However, the urinary bladder is not thick-walled. Now I'm going upwards. I do not see any prominent para-aortic lymphadenopathy. However, okay, once again. Okay, so bilateral kidneys show no hydronephrosis. No mass lesion is noted in the region of the bilateral kidneys.
Both kidneys are normal and the perinephric spaces are clear.
A hypodense lesion is seen anterior to the aorta.
Yes, perfect.
Yeah, lobulated with the anterior to the IVC, which is mildly compressing the IVC as well.
Perfect. Is it aggressive or not aggressive?
It appears to be non-aggressive as the fat planes with the IVC are preserved, but it's causing the adjacent mass effect.
Yes. Is it solid or cystic?
Low attenuation. I would like to take the Hausenfeld units to look at its density.
Yeah, it's fluid dense.
Yeah, okay. But yeah, okay. With the urinary
What's your diagnosis?
Compare that. Sorry?
What's your diagnosis? What's your diagnosis? What's your differential diagnosis?
Okay. Here, I would like to see it doesn't have any communication with any of the organ? It can be
Nothing.
lymphocyte
Yes,
or
perfect. It's lymphatic malformation or lymphocele. Yeah, perfect. It's cystic, lobulated, fluid density. May we have some flakes of calcifications in between.
Yeah.
And if we have something like this, we should compare with the previous scan to check is it stationary or not. And this one is considered as lymphatic malformation, one of the most important retroperitoneal structures. It's characterized by cystic fluid content. Okay, sometimes flakes of calcifications. Okay, and as you said, it's not aggressive. It's causing a mass effect as you described. Okay, thank you so much, candidate number 3. Can we move to candidate number 4, please?
Yes, sir. Assalamu alaikum.
Wa alaikum salam. How are you?
I'm fine, thank you.
Alhamdulillah. Let's okay. May we try to make it like this one? I don't know. Is it okay? Okay. Can you please send for me a request for remote control?
I'm unable to send the request. I don't know why.
Okay, I will scroll for you. Okay, no problem.
All right, I have found it. You can just accept
Yes.
it.
Okay, go ahead. Okay, you
Thank
can
you.
scroll from here.
Sure. Okay, I'm provided with contrast enhanced images of CT abdomen, axial slices. I'm scrolling from the whole stack and then I would comment on the findings. I'm going from top to bottom, in which I do not appreciate any significant pathology in the sections through liver. Gallbladder appears unremarkable. While going downwards, I can appreciate in ill-defined hypodensity noted in the aortocaval region, which is displacing the IVC towards right
Yes,
side and
perfect. Yes.
displacing the pancreas anteriorly
Yes.
with some blurred fat planes with the pancreas. However, there is no
Yes.
significant invasion or compression of IVC or aorta is noted. Although this is a contrast enhanced study, but I think I can appreciate some few faint calcific foci within it. The pathology is predominantly on the right side with no extension across the midline. It is just encircling the vessels without any invasion. There is no significant compression upon the right renal pelvis. This on left side, right kidney is also unremarkable. No
Okay.
definitive pathology is noted within the left kidney. While going downward, I can see that this thickening is now extending towards midline while staying anterior to the aorta and displacing the vessels.
Okay,
And
is this mass
possibly this is the-
enhancing or not enhancing?
It
Yeah,
shows
you
faint-
describe the mass very well. This mass is centralized on the central portion of the retroperitoneal structures between
Yes.
the aorta and IVC, aortocaval space, and the retrocaval also, and encircling the IVC without obstruction and displacing the pancreas anteriorly. It shows
Yes.
some flakes of calcifications. Very nice. Is the mass enhancing or not enhancing?
It may be faintly enhancing, but not very good
Okay.
enhancement.
Yeah.
You might
Okay.
like to
Yes.
compare field units
Yes.
with the pre-contrast study, but
Yes.
considering its invagination into
Yes.
the different compartments or just encircling the surrounding viscera without any
Okay.
invasion.
Yeah. You told me
If,
also that the margins are for a little bit poorly defined. It's not
yes,
too much
it's
well
not
defined.
well-defined.
Okay.
Yes, it's
Yes.
not well
Very nice.
defined.
This is the arterial phase and this is the venous phase. It's not venous really, it's delayed phase.
It's delayed
Is it
phase,
enhancing
yes.
or not enhancing?
No significant difference is noted between the
Maybe minimal
arterial
contrast enhancement. Yes.
or
Minimal,
the
very minimal. Okay.
very
What's your
minimal.
differential diagnosis?
So considering the location as well as the imaging characteristics, had it been enhancing, it could have been a lymphomatous lesion, but as it is not enhanced,
Maybe lymphatic
I
malformation?
Yes, I think this is a lymphatic malformation because it is
Okay.
invaginating into the surrounding tissues.
Okay, what else?
I would like to compare with the previous imaging if available, and I would also like to check the Hounsfield unit of this lesion if it comes into the.
Okay, this is a MRI for the same patient. It displays dark signal. Is it matching with? I think it's some the lesion displays mixed high signal and dark signal.
on
Is it
T2 weighted
matching with,
images.
yeah,
So this can be retroperitoneal fibrosis also, because fibrosis is
maybe,
low on T2 weighted
but
images.
is it this one is classic space for retroperitoneal
No,
fibrosis?
it's not classic. It is usually
Yeah,
bilateral
okay,
para-aortic, not in the
yes,
aortocaval region only.
yes, perfect. Okay, what's your other differential diagnosis? What are the retroperitoneal masses? Because this mass is not
Retroperitoneal,
cystic. It's not cystic. It's solid
it's
mass.
not cystic, it's solid.
Okay.
It
Yeah.
can be
What's your differential diagnosis?
the differential diagnosis for retroperitoneal masses include the retroperitoneal sarcomas, but it's not a destructing
Okay.
lesion. But as it has blurred fat planes, it can be a low-grade sarcoma.
Yes.
I would
Retroperitoneal
keep it
sarcoma,
in
one
the
of the
differential
best
diagnosis.
differential diagnosis in this case. Okay. What
And
else?
then it can be retroperitoneal lymphoma also. It can be
Lymphoma, maybe, but it's difficult because it's like one mass encircling. But maybe lymphoma, yeah, it's one of the differential, but it's not enhancing mass.
It's not
it's
yes.
not similar to lymphoma really. Okay, what else? But it's one of the differential. Okay, what else?
Considering the masses in the retroperitoneal
You said
region.
retroperitoneal sarcomas,
Yes,
lymphoma.
retroperitoneal
We
sarcoma.
already ruled out lymphatic malformation. What
Lymph
else?
lymphatic
Yes.
malformation. It cannot be. It cannot be
You have,
retroperitoneal.
we have one important differential in this case. What else?
I can appreciate the whole
Neurogenic
outline.
tumor. Neurogenic tumors. Don't forget neurogenic tumors. Nerve sheath
yes.
tumors, sympathetic ganglionic tumors, paraganglionic tumors. Okay, this one is considered one of the sympathetic ganglionic tumors. This is ganglioneuroma. Okay, biopsy proved. Yeah, ganglioneuroma. We have sympathetic ganglionic tumor. We have 3 types, either neuroblastoma and
I'm unable to scroll it. Okay, thank you. Axial slices in which the striking abnormality I can appreciate.
Can you please focus on the kidney, on the right kidney?
Yes,
okay.
Yes.
To save
I'm
your
going
time.
there.
Okay.
Yes. The striking abnormality I can appreciate is that there is an ill-defined area noted just adjacent to the lower pole of the right kidney. It is predominantly in the posterior perinephric space, and it is infiltrating. It is extending into the posterior pararenal area, as well as involving the adjacent psoas muscle, which has blurred fat planes with the lesion and is also thickened as compared to the left side. This ill-defined area of enhancement shows internal necrotic component as well. I do not appreciate further abnormally enhancing lesion within the kidney. And the right, now I'm looking at the renal vein. The right renal vein, although it's not a venous phase imaging, but it is patent. The renal artery and contralateral kidney appears unremarkable. There is no significant dilatation of the pelvic ileal system.
Yes. What's your diagnosis here in this case, please?
If there is any history of fever, then this can be due to some abscess within the kidney, which is extending into the perinephric
abscess. Yeah,
space.
correct.
And,
just I want to add, this is another example for perinephric abscess because it's very important. What is the most common organism or bacteria here in this case?
In this
any case of perinephric abscess, what is the most common?
Usually these are gram-negative bacteria, E. coli, Klebsiella.
E. coli, you are right. Okay, thank you so much. Can we move to the next candidate, please? Candidate number 5. Thank you so much. Candidate number 4.
Yes, Assalamu alaikum.
Yeah, wa alaikum salam. Okay, so how are you? Candidate number 5. How are you?
Alhamdulillah.
Yeah, can you please scroll from here if you want? If you want me to scroll for you, no problem for me.
Okay, sir, you can scroll for me.
Okay. This patient was complaining of right hypochondrial pain.
Okay, I'm provided with the CT abdomen plain images, in which I can appreciate that there is stone in the gallbladder. Now, as I'm going down, I can appreciate there is a fat density lesion in the suprarenal location of the right suprarenal region with internal soft tissue component.
Yes.
Right kidney is displaced inferiorly.
Yes.
Left kidney appears unremarkable. I want to see on the coronal images if there is any communication of this fat density mass with the kidney. However, the left adrenal
Perfect.
gland is
You are
not being
perfect,
visualized.
candidate number 5.
I cannot
You
appreciate
are so
the right
perfect. Okay.
adrenal gland.
Okay. Okay. We have like as you described, we have a large retroperitoneal mass. It is centered upon the right adrenal gland region, and it is smoothly indenting the right hepatic lobe anteriorly.
Right
It is
hepatic
displacing the IVC medially. It is displacing the kidney inferiorly. And well done. You should compare, or you should correlate with the coronal plane to check is it arising from the kidney or not. It's not arising from the kidney. Okay, what's your differential diagnosis?
So it's the right adrenal gland lesion. My differential in this case include myolipoma, adrenal myolipoma.
Yes, adrenal myolipoma. Okay, very nice. What else?
Other adrenal lipomas is also the possibility, but there is also soft tissue component, so likely myolipoma. Fat-rich adenomas is another possibility, but they are
adenoma,
not
it's very
so
it's not
yes,
in our differential diagnosis. We have adrenal myolipoma, one of the top differential diagnoses, because maybe arising from the adrenal gland. But what else? Because the adrenal myolipoma, once we have any fat containing lesion more than 5 centimeters, okay, adrenal myolipoma is one of the differential. But what else? Because this is huge mass. You should put 2 differential diagnoses.
So there is possibility.
Myeloboma and what else? It's not arising from the kidney, okay? Liposarcoma, yes. Don't forget liposarcoma, okay?
Yes.
Maybe liposarcoma at this, maybe liposarcoma at this place. Please don't forget this one. Don't write it adrenal myeloboma and full stop. It's most likely, or the top differential is adrenal myeloboma. I agree, but don't forget to put another differential diagnosis and either biopsy or at least follow up. Okay. Okay. We have also gallbladder stones. Okay. Please keep with me. This case, yeah. I will scroll for you. This case.
Okay. Okay. So this is the CT abdomen post-contrast arterial phase images, in which I can appreciate there is soft tissue, hypodense soft tissue mass in the posterior to the left atrium.
Okay, let's start first by the abdomen. Let's start by the abdomen. Can you give me description for this abdominal mass? Yeah.
Yes, there is a soft tissue mass in the para-aortic region, which is encircling the encasing the aortic vessels and anteriorly displacing the pancreas.
Yes.
This mass is also encasing the left renal vessels.
Yes.
And I'm looking for there is a hypodense area in the IVC, but this is not a photovenous phase.
Yes, it's ignore this one. It's this one is flow artifact. Okay.
Okay.
So we have retroperitoneal mass.
So
is it enhancing or not enhancing?
Mass. What do you think? Encasing the aortic vessel. It is not enhancing.
It's not enhancing. Yes.
Not enhancing.
No significant enhancement, and it's encasing the celiac trunk. It's encasing the superior mesenteric arteries, renal vessels. Yes, not obstructing these vessels, but it causes mass effect, as you described, displacing the pancreas anteriorly. Okay, this is, and also we have retrocrural extension also. Yes, this compartment. Yes, and this mass lesion is extending to which one?
There is nodal.
It's extending to the posterior mediastinum. Is that correct? Through the esophageal hiatus here. Okay. Can you please give me more description here? Candidate number 5. Where are you? To save your time, this posterior mediastinal mass It's
There
extending
is also a
superiorly.
well-defined
Yeah,
superiorly,
again.
Superiorly extending into the superior mediastinum, where there is a well-defined large nodal mass, which is displacing the trachea towards right side.
Right side.
There are also
Perfect.
multiple other hypoenhancing nodal masses in the prevascular space.
Yes. Yes, prevascular, aortopulmonary space, and the
left paratracheal,
yes,
left paratracheal and
paratracheal,
and
retrotracheal,
subcranial region.
Subcranial. Okay, perfect. What's your differential diagnosis?
So my most likely diagnosis is lymphoma.
Okay, but it's not so enhancing.
Multiple. Yes, it's not.
What else?
Like,
Retroperitoneal and posterior mediastinal masses.
Masses, yes.
Yes.
Could be any infective like tuberculosis.
Tuberculosis, it should be like lymph nodes, maybe with central caseating components, non-enhancing components. It doesn't look like this one, really. It's not tuberculosis infection.
So other possibility of for non-enhancing masses is lymphatic malformation.
Lymphatic malformation.
That will not be so much extensive going into the
maybe, but this one of the masses, it shows margin contrast enhancement. But maybe in our differential, but it's not typical really. Okay, what else? Retroperitoneal masses. Retroperitoneal masses, maybe neoplastic. Yes.
Nerve sheath tumors.
We have retroperitoneal masses, maybe retroperitoneal sarcoma, as we said, maybe neurogenic tumors, maybe lymphomatous, maybe germ cell tumors. But if I want to tell you this one is neurogenic tumor, how can we confirm?
I will look their extension into the neural foramen.
This one is so much extensive.
But this is so much large. It could be plexiform neurofibroma arising from the sympathetic.
Perfect. How can we confirm? Yes, because it's very extensive.
So I will take the history of the patient. If the patient has other criteria for NF1, including any skin lesions or any other, I will advise neural axis imaging to rule out neurofibromas and optic nerve gliomas in the brain.
Okay, can you check the skin, please? You will find multiple. Look for this one. Multiple skin nodules. Before in your exam, before asking the clinician, check the skin itself. This is the key in this case. Skin nodules, multiple skin nodules with retroperitoneal masses, extensive masses like this one. This one was proved as plexiform neurofibromatosis with malignant degeneration or malignant transformation or sarcomatous changes. This one was proved on biopsy, okay? But at least we are thinking of neurogenic tumor because of these skin nodules. Don't forget to check the skin nodules in these cases, okay? Okay. Thank you so much. Candidate number 5. Did you share with me one case or two cases? Candidate number 5.
Two cases.
One case or two cases? Two cases?
Two cases. Yes.
Yeah. Okay. Thank you so much. Can we shift to candidate number 6, please? Candidate number 6. Yes. Hello. How are you?
Yes. I'm good, sir. Thank you. How are you?
Okay. Okay. Let's move to this case.
Okay. So,
if you want to scroll, I'm happy.
I'm unable to.
Okay, no problem. I'm happy to scroll for you. No problem.
Okay, sir. Thank you.
Welcome.
So I can see that this is a CT of the abdomen axial sections with contrast, abdomen and pelvis. I can see that there is a large hypodense lesion, which is seen in the retroperitoneum, especially arising from the left side of the retroperitoneum, extending all the way from abdomen to the pelvis. I would like to measure the Hounsfield units, but I think it is likely a cystic lesion.
Yes. Okay.
So based on the lobulated and intervening septations, which I can see, I'm suspecting this could be a lymphatic malformation in this patient.
Okay, perfect.
So
before going to the diagnosis, can you please enumerate for me the spaces
so we have
that was involved by this cystic mass?
So it's so I will just go up towards the pancreas if it's involved. So pancreas, I can see it's involving the region of pancreas as well. So it's involving the anterior pararenal space.
Yes, perfect. This is the anterior pararenal space.
And then
the colon and the pancreatic body and tail. This one, all of these structures are present in the anterior pararenal space. And also, it's confirmed. How can we confirm that this one is retroperitoneal structures? Because it is displacing the descending colon anteriorly, and also the mass is present
surrounding the renal fascia.
Yeah, it's perirenal space.
Perirenal, pararenal.
Yes. And this one?
Pararenal space.
What is this space?
This is the inferior space which extends from the pararenal fascia down towards the pelvis.
I think this one is peritoneal space. So this one is peritoneal. It's not retroperitoneal. So we have mixed between retroperitoneal spaces and peritoneal spaces, and this one of the most characteristic features of lymphatic malformation, transcompartmental extensions. It doesn't or it is not bounded by reflections. It is crossing the reflections, crossing between retroperitoneum, peritoneum, and also different retroperitoneal structures, different retroperitoneal spaces. So this is classic features of lymphatic malformation. Perfect. Okay. This case was complaining of left loin pain.
Okay, so these are the axial CT abdomen with intravenous contrast.
Yes.
So I can see that in the left suprarenal region, I can see that there is a mass which is having some soft tissue and cystic areas. I think it is in continuity with it appears in continuity with the left ovarian vein, as it's arising from the left renal vein and extending down towards the ovaries. I don't see the left ovarian vein.
Perfect. Fantastic.
So I'm suspecting a mass arising from the left ovarian vein, which has this solid and cystic components. So I'm suspecting this could be a malignancy, probably arising from the wall of the vein. So it's likely to be a sarcoma. I will.
Which type of sarcoma?
Leiomyosarcoma.
Leiomyosarcoma, yes, perfect. Yeah, can you give me the hand, please? In this case, this is the left renal vein, and this is a mass just below the left renal vein, maybe continuous with the left renal vein, as you can see here. So it looks like an aggressive retroperitoneal mass. As we said, sarcomas, one of the differential, neurogenic tumors, one of the differential, but this one, the key points here is the continuity. Look for this one. This is the kidney, and this is the left renal vein, and this is the mass. It is inside the left ovarian vein, and as we described in our last session, that one of the differential diagnosis, once we have any aggressive mass continuous with IVC, ovarian vein, or any vascular structures, you should think of leiomyosarcoma, specific type of retroperitoneal sarcomas. Thank you so much.
I'm just going to scroll through the images before I give my comments.
Okay.
Okay, so I'm going to go back to what I thought was the area of concern. So there is a mass which I can see anterior to the right kidney and posterior to the IVC.
Perfect.
This looks like a rounded lesion which is showing heterogeneous enhancement.
Yes.
With maybe some central areas of necrosis. It is separate from the right adrenal gland. It is abutting the anterior cortex of the right kidney, but there is a fat plane between them, so it doesn't look like it's arising from there. Then it is causing some mass effect on the IVC, and it is in close contact with the IVC. So it is possible that it could be arising from the IVC, or it could be coming from the retroperitoneal fat itself and closely maybe abutting or invading the IVC. So I think
it is abutting the IVC. It's not infiltrating the IVC. I think it's not separable, but it's not arising from the IVC itself.
Yes. So because it doesn't seem to be arising from any of the structures around it, by exclusion, I suppose it is arising from the retroperitoneal fat, the retroperitoneal space, sorry. So my differentials for such a lesion.
So what's your differential diagnosis, please?
So this could be it could be a necrotic lymph node, but I don't think I've seen any other.
Very nice. If it is, if this structure is lymph node, what should you do?
So if this is a lymph node, then I would want to look for a primary lesion. I haven't seen a primary lesion so far. I'm wondering if this is a male patient. So I'm just going to go down. Okay. The pelvis has not been covered. If this is a male patient, then it could be maybe coming from a seminomatous.
Yes, testicular neoplasm. Okay. If it is female, if this patient is female patient.
If it is a female patient, then I would still want to look at the pelvis. It could be a metastatic, maybe cervical or an endometrial.
Yeah, very nice. Choriocarcinoma or uterine. Yes, very nice. Okay. Also, don't forget to check colorectal carcinomas and prostatic carcinomas. All of these are maybe the source for metastatic lymph nodes or retroperitoneal metastatic lymph nodes. Okay, what else? If this one, it is not lymph node, what else?
So if this is not a lymph node, then I would think of primary retroperitoneal tumors. It does not look like a sarcoma, at least not a liposarcoma, and it's not coming from the IVC, so I wouldn't think of a leiomyosarcoma. It could be a neurogenic tumor.
Okay. So which type of neurogenic tumor?
It could be a nerve sheath tumor.
Perfect.
So
maybe nerve sheath tumor, maybe schwannoma. Is that correct? Maybe neurofibroma, maybe. Okay, what else? Because this mass is slightly bit enhancing with central breakdown, but it's almost enhancing mass, avidly enhancing.
So it could also be like a ganglioneuroma or a ganglion.
Maybe ganglioneuroma. Okay, one of the differential. What else?
Then other possibilities. I don't think this is the location for a paraganglioma. They're usually seen around because they're usually seen around the aortic bifurcation, where the organ of
it can be at any site of the autonomic nervous system. It can be paraganglioma, and it is paraganglioma.
Okay. Yeah, so the sympathetic.
The most important question for the physician is to ask the physician, is the patient complaining of hypertension or not, or resistant hypertension or not? Yeah, in this case, really presenting with hypertension, searching for paraganglioma, and it was paraganglioma. Okay, so but you did very, very well. First, you should think for metastatic lymphadenopathy. You should think for any retroperitoneal neoplastic masses, sarcomas, but it doesn't look like sarcomas. Maybe neurogenic tumors. We have different types of neurogenic tumors. One of the differential diagnosis for neurogenic tumors is paraganglioma, as you can see in this case. Thank you so much, candidate number. So let's review our differential diagnosis for perinephric masses. We have perinephric neoplasms. Angiomyolipoma can be exquisite, extruding or protruding into the perinephric space. Renal lymphoma, as we saw in our cases. Retroperitoneal sarcomas can extend into the retroperitoneal perinephric space. Infection as perinephric abscess, as we saw. Also perinephric hematoma, as we saw in our trauma case. Extramedullary hematopoiesis, retroperitoneal fibrosis, and perinephric myxoid tumors. But those are the most important differential diagnosis. Let's review our retroperitoneal anatomy again. This is the anterior pararenal space, and this is the perirenal space, and this is the posterior pararenal space. The anterior pararenal space, it is bounded anteriorly by the posterior parietal peritoneal layer, while posteriorly it is bounded by the anterior renal fascia, and laterally it is bounded by the lateral conal fascia, while the perirenal space, it is bounded anteriorly by the anterior renal fascia and the posterior renal fascia. And the posterior pararenal space, it is bounded anteriorly by the posterior renal fascia and posteriorly by the fascia transversalis and anterolaterally by the lateral conal fascia. The anterior pararenal fascia contains the descending colon, the ascending colon, the second and third part of the duodenum, and most of the pancreatic tissue. Some points. We have, as we said before, that we have perinephric collection, and you will find some bridging septi, as you can find here. These are considered as channels that start to decompress the kidney or start to decompress this perinephric collection to be drained outside and relieve compression upon the kidney. So once we have these channels, these are bridging septa. In the sagittal plane, you can find U-shaped configuration. It consists of anterior renal fascia and posterior renal fascia, and this plane is common interfacial plane, as you can see here. So this is posterior pararenal space, while this all of this space is perinephric spaces. As we discussed, or as we said before, that the renal fascia, either anterior or posterior renal fascia, it is not one layer, but it is multiple layer, multilaminated layer. Sometimes these layers expanded by free fluid collection. As you can see here, this minimal fluid collection expanding the anterior renal fascia. Once we have expanded anterior renal fascia, we can call it retro-mesenteric plane. So it is now considered as retro-mesenteric plane. One of our cases that we discussed before, we have a large retroperitoneal hematoma extending to the posterior pararenal space, as you can see here. But we have at the same time, this is a posterior renal fascia. It is expanded by fluid content. So we can call it retrorenal plane. So we have also the lateral conal fascia, as you can see here. It is also expanded by the reactive fluid collection. So we have lateral conal plane, not fascia now. It's expanded, so we can call it lateral conal plane renal plane, the retro-mesenteric plane, it's not expanded in this case. Any retroperitoneal masses, we can think of neoplastic masses, non-neoplastic masses. The top differential diagnosis for the solid retroperitoneal masses, neoplastic masses, neurogenic tumors, primary retroperitoneal sarcomas, lymph nodes, metastatic or lymphoma, germ cell tumors. Also, we can see retroperitoneal fibrosis, extramedullary hematopoiesis, Erdheim-Chester disease. We saw this one and this one. We saw lymphoma, metastatic lymph nodes. All of these examples we saw in our cases before. If we have cystic retroperitoneal masses, the most common is lymphangioma. This is the most common. We have other less common differential diagnosis. This article is very important to review practical approach to primary retroperitoneal masses in adult. Neurogenic tumors, we have 3 types of neurogenic tumors: nerve sheath tumors, schwannoma, neurofibroma, malignant nerve sheath tumor, sympathetic ganglion tumors, neuroblastoma, it is the most aggressive and it's common in the pediatric age group. Ganglion neuroblastoma, it's mixed between benign and aggressive features or malignant features. Ganglion neuroma, it is considered as a benign form of neurogenic tumors. It's more common in the adults. We have also paraganglionic system tumors, paraganglia, and don't be confused because this one can be classified into sympathetic and parasympathetic, as we can see in the next slides. So don't be confused. This is sympathetic ganglion tumors. This is paraganglionic system tumors, and this one can be classified. Let's review paragangliomas or glomus tumors. We have this is uncommon neuroendocrine tumors. It is classified into sympathetic, as we said before, and the parasympathetic paraganglia. Sympathetic, it is more common in chest and abdomen, and it's commonly excretory tumor. So this tumor can excrete catecholamine, causing hypertension and palpitations and all of these symptoms. It is classified into intraadrenal. We can call it pheochromocytoma, and extraadrenal, it's more common in abdomen along with the organ of Zuckerkandl from superior mesenteric artery down to the aortic bifurcation. Also, it can be present in the bladder base. It can be present in the posterior mediastinum. So this one is called sympathetic paraganglia. On the other hand, we have parasympathetic paraganglia. It's more common in the head and neck. Most commonly, or it is more common to cause mass effect, not secreting any hormones, as you can see, and we have different types. The most common is carotid body paraganglioma. As you can see here, the paragangliomas can be classified into parasympathetic and sympathetic. Sympathetic, it is localized in the posterior mediastinum and retroperitoneal structures in the abdomen, while parasympathetic, it's more common in the head and neck groups. Primary retroperitoneal sarcomas, the most common is liposarcoma. Well-differentiated liposarcoma, it is the less aggressive form. Atypical lipomatous tumor, this is the same histological pattern, but atypical lipomatous tumor, it's more common in the extremities, while differentiated liposarcoma, it is more common in the retroperitoneal spaces. We have also myxoid and round cell liposarcoma, dedifferentiated liposarcoma, pleomorphic liposarcoma, and mixed liposarcoma between both or all of these types. Take care of some important points here. Well-differentiated liposarcoma, it is huge mass with thin septations, and it doesn't metastasize, okay? And very rare to see any calcifications with them, okay? Well-differentiated liposarcoma. While the higher grades of liposarcoma, when you are going down to the higher grades of liposarcoma, the tumor is metastasized. It will be associated more with cystic changes and necrosis, calcifications, and all of these features. While well-differentiated liposarcoma, it doesn't metastasize, but it has high incidence of local recurrence after surgical intervention. We have also leiomyosarcoma. If the tumor is invading or arising from any vascular structures, undifferentiated pleomorphic sarcoma, and the updated term is malignant fibrous histiocytoma. Let's have some clues to identify the retroperitoneal masses. If we have fat-containing retroperitoneal masses, we should think of liposarcoma or lipoma. Lipoma, it's very rare to see lipoma in the retroperitoneal spaces. Once we have fat-containing mass, we should consider liposarcoma until proved otherwise. Extramedullary hematopoiesis, it can contain fat components. Teratoma. The mimics is angiomyolipoma if it is arising from the kidneys, and adrenal and extra-adrenal myelolipoma, as we saw in one of our cases. Retroperitoneal fibrosis, our definition is proliferation of the fibrofatty tissue encasing the infrarenal abdominal aorta, IBC, iliac vessels, and ureters. The causes are idiopathic or secondary to drug or secondary to any inflammatory process. We have two types of retroperitoneal fibrosis, acute type or chronic type. Acute edematous highly vascular tissue, so it will display hyperintense signal in T2, while chronic it is fibrous flakes, so it will display hypointense signal in T2 PET image. Here it is highly vascular, so it will show intense contrast enhancement, while chronic form of retroperitoneal fibrosis, it will show minimal contrast enhancement. Retroperitoneal lymphomas, we have two types, Hodgkin and non-Hodgkin. Imaging features lymphadenopathy, bulky retroperitoneal lymphadenopathy. Vascular involvements, it can cause sandwich sign when this retroperitoneal lymphadenopathy encasing the vascular structures. Floating aorta sign, the aorta will be encased by lymph nodes and displaced anteriorly, as we saw in one of our cases. How can we differentiate between retroperitoneal fibrosis and retroperitoneal lymphoma? We have multiple factors or multiple items to differentiate, but remember these points. Retroperitoneal fibrosis more or less homogeneous. Lymphoma, it's more or less heterogeneous. Retroperitoneal fibrosis is dislocalized mid-aorta in L4-5 level, and these soft tissue sheets encasing the anterolateral aspect of the aorta and sparing the posterior aspect of the aorta. No anterior displacement of the abdominal aorta. It encases but not obstructs the ureters, so it can cause medial displacement of the ureters, but it will not obstruct the ureters. It can cause encasement and obstructions of the venous channels with secondary collaterals, venous collaterals. Lower PET uptake than lymphoma and higher ADC values than lymphoma. So lymphoma, it is more restricted than retroperitoneal fibrosis. On the other hand, lymphoma is manifested as soft tissue masses or sheets encasing all aspects of the aorta, plus or minus anterior displacement of the aorta. It can cause anterior or lateral displacement of the ureters, encasement without any obstruction for the vascular channels. As we said, it can cause significant diffusion restriction and higher bed out. As we can see here in our case, this is soft tissue sheets encasing the anterior and anterolateral aspect of the aorta and sparing the posterior aspect of the aorta, while here the aorta is displaced anteriorly and encased in all aspects of the aorta. In Erdheim-Chester disease, as we discussed, we have bilateral soft tissue infiltrates encasing the both kidneys. And this disease is rare, multi-system, non-Langerhans cell histiocytosis. We have skeletal involvement and extraskeletal involvements. Skeletal involvements, symmetrical metaphyseal and diaphyseal sclerosis. Extraskeletal involvements, the most important is cystic lung disease, as we saw in our chest cases. Retroperitoneal hair kidney signs, irregular symmetric infiltration of the perirenal and posterior pararenal spaces. It can cause also retroperitoneal fibrosis. CNS, it's very important to see the hypothalamus and pituitary gland. Loss of the posterior pituitary bright spot in T1 with image and thickening of the infundibulum. So this can cause diabetes insipidus. Leptomeningeal disease can be present, but it is uncommon.
Scan. I'm provided with CT scan of abdomen in post-contrast images in axial view. I'll first quickly scroll through the stack and go to the last image, and then I will give my findings. I'm going to the last slide, and okay, now I will scroll back up.
Go back, yes, because this was chest abdomen pelvis. Okay.
Okay. I'll go back. So I can appreciate there's a DJ stent in place within the left kidney, within the left ureter. I can see there's I'll go back to the area of interest. Okay, now I can see an area of soft tissue density mass in the para-aortic region at the level of left renal hilum. It shows central areas of necrosis. I cannot see any calcification within it. This lesion is encasing the left ureter and also indenting upon the left kidney. Due to this lesion, I can also appreciate there is some mild hydronephrosis within the left kidney. This lesion is lobulated, and I can see a component that is I can see a component that is partially encasing the aorta. However, I cannot see any invasion of the aorta or the renal vessels. Actually,
Okay, 1 second. I will go back with this comment. Did you see?
Yes, I can see this lesion is extending into the left renal vein.
Well done, excellent. Okay, go ahead.
Okay. There's another similar lesion within in the posterior to the inferior vena cava, which is displaced anteriorly by this by the lesion. Another I can. Another retrocrural, right retrocrural lesion can be seen with similar.
Bilateral
sorry?
retrocrural? Bilateral
No,
retrocrural?
right retrocrural.
Okay.
I'll look at the left side too. No, yes, it's bilateral retrocrural. I will now go and see if there's any involvement within the mesentery.
Can I ask you one specific question?
Yes, sir.
Which phase in this study? They already imaged it in single phase. Which phase this one?
This is portovenous phase.
In our genitourinary system, which phase this one?
Okay. Let me see. So this is a nephrogenic phase.
Nephrogenic phase. Are you
No.
sure this is
No.
nephrogenic phase?
No. This is a corticomedullary phase. I can see the differentiation in the left kidney.
Actually, let me correct you.
Yeah.
Your first answer was extremely nice. This is nephrographic phase of the study. But what happened with the left kidney? It is corticomedullary.
Okay, it's because
what can this answer me?
it's compressing upon the right renal artery. Actually, it's because the left renal vein is invaded.
So this is obstructed kidney. You want
Yes,
to tell me exactly this is compromised the renal function on the left side, okay?
Yes, sir.
And that was actually one of the questions the physician want to. Can you give me, if you please, differential diagnosis of what you are seeing right now?
So this can be a lymphoma. However, lymphomas do not generally invade vessels. They tend to displace and encase vessels. Other possibility could be a retroperitoneal sarcoma with lymph nodes with a lymphatic spread to the retrocaval space.
Actually, my dear, there is one clue in this scan. Can you spot the clue? It will give you a straightforward only one diagnosis for this case. You scroll, and if you found it, you will be 10 over 10. You did very well actually in describing and already in giving us one of the serious complication, which was the left renal vein invasion or extension of this process. But there is one clue in this case. 5 or 6 minutes back, actually, this was the last case of Dr. Muhammad. He put one exactly similar case to that one. And I think the previous candidate for you listed a very good strong differential diagnosis for that one. Can you please give me the control?
Yes, sir.
Okay. Let me check with you. Actually, you described very well, and you didn't forget the serious complication, extension of this process into the left renal vein. It is very clear and obvious here. But there was one thing, never to finish the scan without this area. Actually, this was a male patient. Okay, you scroll, you found the prostate. What is this?
Sir, these are post-surgical changes.
Excellent. For what? What can cause this infiltration and haziness? What is this? What is the anatomic location? What is this?
Sir, it appears to be the inguinal canal.
Excellent. Okay, what is this?
Yes.
So this is post.
Can we scroll? Sir, is it post orchidectomy?
Nice, excellent. This is post left orchiectomy for this case with spermatic cord removal, and this is the post-operative. Now you give me one diagnosis for this case and what you should inform the physician. This is multiple para-aortic metastatic adenopathy from a case of seminomatous tumor. Exactly? You still with me? Candidate number 9. Candidate number 9. Where are you? Can you hear me?
Go ahead, Dr. Fathallah.
Okay, that actually that was a case, very good, strong presentation after Dr. Muhammad gave us very multiple amazing. Yeah, you are here?
Yes, sir. I lost my connection. I'm now using my iPad to connect.
Okay, actually this was a case of seminoma, post left orchiectomy. Never to underestimate the left inguinal canal from this one, and this was metastatic para-aortic lymph node with invasion of the proximal left ureter, left renal pelvis, and getting actually inside the left renal vein, and this is very bad prognosis for this case. Okay, plus the bilateral retrocrural. What else you should comment?
Tell
me.
I'll just look at the bones, and I'll also look at the liver for any hepatic metastasis.
Can I ask you a straight question? Is it common
Yes.
to found inguinal and iliac lymph node in such a case?
No, sir.
No, sir. So if you found inguinal and internal iliac lymph node in that case, and it is also having the similar consistency of infiltration, what do you think? Is that direct extension, or this is infiltration of the? Tell me.
Maybe it's infiltration from the gonadal vein.
This is actually will be infiltration of the lymphatic of the scrotal wall itself.
Okay, sir.
You got my point?
Yes.
So when we finish that case, we should inform him it is non-functioning. At least it is slightly functioning double G catheter in place, because there is residual and there is compromise of the function. Can you see here? This is, as you say, nephrographic phase, but this is still remaining in the corticomedullary phase. The moment we will see that one, we know already it is obstructed kidney.
Okay.
You got my point. And the second thing, don't forget that one, the thrombus inside the vessel. Okay, this is encasement of the artery and invasion of the left vein. Okay. Thank you for your marvelous participate. If you please stay for me for another case. Actually, this is a straightforward case. You can take the control. You still have the control.
I can't take control because I can't use my computer right now. My computer shut down.
But okay, no problem. Let me scroll for you. This is a young boy presented with abnormal QB ultrasonography. Okay.
Okay, sir. So I'm provided with axial T1 weighted images of pelvis of the of a male patient, in which I can appreciate there's a hypointense lesion posterior to the urinary bladder on the left side of the pelvis. This is I will like to scroll a little to see if it's spontaneous with the
Actually, this is the T2. You can prescribe this lesion for me.
Yeah, it's a T2. So there's this lesion is cystic. This lesion is cystic and is spontaneous with the posterior wall of the urinary bladder. It can be a urinary bladder diverticulum, or it can be ureterocele. However, ureteroceles are usually within the bladder. It can also be a seminal vesicle cyst.
Excellent differential diagnosis. You got Continue. What should also you can review for this case? What you will search in this case?
I will see if there's any. I would like to see the ureters and the kidney.
Nice. Okay. This is the coronal for this case.
Okay. Okay, so I can not appreciate the left kidney. I can appreciate that the right kidney is enlarged. Coming back to the lesion, the lesion is it appears to be extending upwards. Okay, that's bowel. So this is a
Can
case
you tell
of
me what?
This is a case of Zinner syndrome.
Excellent. Excellent. Very good. You did well. Continue. What is Zinner syndrome?
Zinner syndrome is a congenital anomaly where there's a seminal vesicle cyst with absence of ipsilateral kidney. Yes, I will. I will inform the pediatric urologist of my findings and
what is the clinical presentation in this case?
So I'm not sure.
Can you state it?
I'm not sure.
That boy will not get you at this time. It will come to you in the second or third decades with infertility or subfertility. So we will not discover this one until he is already adult. A lot of cases already discovered in the adulthood, not in the pediahood. He came actually because already there was prenatally, they found only one kidney and cystic lesion.
Okay, sir.
Then later on, they follow up him by this cystic lesion, and finally they did this MRI for him. Actually, thank you for your participate, and you did very well in the first case of this para-aortic lymph node. Can we shift for the next candidate, if you please?
And so should I mute myself?
There is a candidate number, I think. You are
candidate number 10.
Number 10, okay.
Candidate number 10, are you present? Candidate number 11.
We will go back, I think, or we still have...
Candidate number 12. Candidate number 10, 11, 12. Anyone?
Candidate number 13. 13 available.
Okay, 13, go ahead.
Candidate
number 13.
Can go.
Okay. You want to scroll?
Yes.
Okay, give me a remote.
Yes, I send request.
Okay, approved. Okay, you can.
Okay. Okay, first of all, I will scroll the images, stack of images from top to bottom, then I will be able to describe my findings.
Okay.
Here I am looking for, this is the non-contrast, no, this is post-contrast, I think. Okay, so this is a male patient, probably this is a non-contrast
scan
images.
Okay,
non-contrast images. Here I can see there is a there is a large large collection is noted around the left kidney, and there is also high density areas are seen in it.
If you please state it anatomically, like Dr. Muhammad already told us and teach us, state it anatomically.
So this is involving the pararenal space in the left side, and there is a it is extending posteriorly and involving the inferior pararenal space. This appears thickening is noted, which is a high density in it. So this considering if the patient have any history of trauma.
Okay, you can give me, you can at this this state, you can give me a diagnosis or differential diagnosis of this one.
Okay, so this high density is going to be represent the kidney already is appear to be suppressed or immediately displaced to the left side. So these findings of large loculated collection, which appears to be high density, it could be urinoma, it could be hematoma. The mesenteric, I could not see any congestion and thickening about the mesentery.
You want to ask the clinician about questions?
I want to ask any history of trauma.
Okay, and what else? What history you want also to obtain?
There is a fatty areas also seen in it. In the posterior aspect, there are some few loculated areas also seen. So the other differential may also include retroperitoneal sarcoma.
But with high density content?
High density content may be due to hemorrhage in the retroperitoneal sarcoma.
Okay, nice explanation.
So
what do you recommend in this case?
Yeah, in the bladder appears normal. So this large loculated collection which is displacing the kidney toward the left side, there is a high density area is seen, it is extending inferiorly. I could not see any mesenteric fat extending changes. So this likely represent retroperitoneal sarcoma. Differential may include retroperitoneal hematoma, retroperitoneal with the old urinoma, and old hematoma.
What you will recommend? Can we do or can we recommend contrast study for this case?
Yes, we can do contrast study. We can do, if the renal function tests are okay, we can do the both contrast study.
Nice. Actually, you should first state the renal function test for this case. Then you will go for post contrast. Okay. Let me 1 second give you the. You can scroll.
No, I cannot.
I'm sorry for this one. Can you please send me another request if you want to scroll?
Oh, okay.
Okay.
Oh, okay. I'm sending request. Give up the remote control. No, it is not option. I think you controlling it first.
You're still controlling, I think. Try to scroll.
Me? Okay, let me try.
Yes. Okay. You can go. This is the first phase. You can tell me.
Okay. Here I can see there is the kidney appears to be displaced medially.
Okay.
And there is a large again collection is noted. I could not see any excavation of the contrast from the right kidney.
Nice comment. You can continue. Okay.
So there is again it is extending inferiorly. The fatty component is seen at the inferior aspect. I think the differential I told earlier. So this could be retroperitoneal hematoma, urinoma with old collection, or retroperitoneal sarcoma. The other possibility could be neurogenic tumor.
But this is actually fluid density with high content. Stick to the hematoma, okay? First, but you give marvelous differential diagnosis. But stick to the hematoma. You told me there is no extravasation, and this is very strong comment. Nice. Is that this kidney is beige kidney or not?
Sorry?
Is that beige kidney or not?
Beige
kidney or not? You know this term?
I don't know beige. I don't know beige kidney. I don't know.
Beige kidney. This is actually extremely non-functioning kidney by the compression of large subcapsular hematoma. Okay. That's why we did already dual phase scan. Can you give me the control 1 second? I will give you the second phase. Okay. This one. This is the nephrographic phase, right?
Yeah.
You still have reserved parenchyma here, right?
Yeah.
So this is not compromised kidney.
Yeah.
The compromised kidney will not have any perfusion or any function, and that's why already we did dual phase. I would ask you right now why we did dual phase for this case. The first one already you told me there is no extravasation.
Yeah.
That's why we did already the dual phase, because if we saw any contrast locule, that means already this case will be shifted for another modality. Okay?
Yeah.
So what else question you should ask the clinician about this one?
We will see the left ureter, and I will ask the history of any hemoperitic disorder, and history of
yes.
anemias.
Yes. Exactly.
And history of anemias and history of hemolytic anemias, in which there is a spontaneous hematoma formation occurs.
What benefit you have from this delayed image?
Here we can see the pelvic system appears normal.
Okay,
and this
nice.
contrast is excreting the kidney, so kidney is functioning. So kidney
nice.
is
and there is no contamination of this hematoma by the contrast here, so this is not urinoma.
Yeah, this is not urinoma.
So you minimize your differential diagnosis list by the delayed image also, right?
Yeah.
And one important question asking the clinician: is this patient taking any anticoagulant treatment, right or wrong?
Yeah.
Straightforward. If he had any cardiac disease, is he taking any prostatic valve with anticoagulant?
Okay.
Okay?
Okay.
Okay, you did very well. And this is, I think, our second or third case in this session for subcapsular perinephric hematoma. You can
Okay.
stay with me?
Okay. Okay.
Okay. You still have the control, right?
Okay.
You can scroll?
Okay.
Mhm.
Yes, yes, I
Mhm.
have control. Okay, this is
Okay.
again. Okay, this is again the CT scan of the abdomen, basically
Okay.
KUB CT scan, which is non-contrast images. Here I will
Okay.
scroll the. Here I will scroll the images from the top to bottom, and then I
Mhm.
will be able to make any comments. Uh, so here I can see there is a. Looking for the hydronephrosis is seen on the right side. The right ureter is mildly dilated. I'm looking for any this stone,
Mhm.
any stone in the right side, and I'm going down inferiorly, and
Mhm.
here I can see the right ureter is dilated, and the urinary bladder is
Nice.
also
Okay.
catheterized. Urinary bladder is
Okay. Nice.
also catheterized, but I could
Okay.
not see any stone on the right side. Now I will move to the again want to see the left side.
Mhm.
Uh, Here I will go to the left. Quickly I will go to the left kidney, and there is small
Okay.
calculus is seen in the lower pole of the left kidney, small
Nice.
concretion, and minimal hydronephrosis is seen. Left ureter is also minimally dilated. I'm
Mhm.
tracing it inferiorly to the up to the bladder, and here
Mhm.
I am looking inferiorly. So there is no stone is seen in the left ureter also.
Okay.
Uh,
What you can
possible.
give me in this list? If I told you this patient has hematuria, history of hematuria, what you
Okay,
will
there is.
recommend for this scan?
Okay, okay. So there is
Mm.
a small amount of air is seen in the urinary bladder.
Okay,
Mm,
but this is post catheterization, I think.
yeah, probably both
Mm.
post-catheterization,
Okay.
and I am yeah. I want to focus on the kidneys. So
Yes, focus on the kidney.
images are jumping here.
Mm.
Mm, yeah, I am focusing on the kidney. Yes.
Mhm.
Yes, there is a.
Mhm.
Uh, thing is that the left kidney is small and scarred, and
Okay, scarred and small in size.
yeah,
Okay.
there is suspicion of a small mass lesion in the lower pole of the left kidney. But this is a non-contrast study, so
What you will recommend?
I will want to comment on the post-contrast scan. I want to see the post-contrast study to comment
Okay,
on the
minimize.
renal tumor,
Just
renal
a
mass.
second. Okay. Okay. So you are suspicious for renal mass. You can
Yeah,
scroll. Okay. Scroll down and tell me your comment.
yeah. So here I can see. Uh,
Mhm.
mm, yes, now I am able to see the left kidney.
Mhm.
Yes, there is no mass is seen. However,
Nice. Okay.
the filling defect is seen in the renal pelvis, which is a hydronephrosis. So, possibility
Mhm.
of mass in the renal pelvis, especially left renal pelvis, cannot be excluded. If patient has history of lung hematuria and patient history of weight loss, this should be further evaluated. No frank mass is seen in the kidneys.
No frank masses in the kidneys. Okay. Continue. So what else in this scan?
Candidate number
So
13, can you please raise your voice more?
yeah. So the
Mhm.
ureters are appears to be dilated, and so
Nice.
I'm
Okay.
looking for any the mass in the urinary bladder.
Okay.
So urinary bladder, I could not see any mass in the urinary bladder. Urinary bladder pair was thick walled, especially
Nice.
on
Okay.
the lateral aspect. So this needs a cystoscopic examination to exclude in any early bladder tumor.
let me stop you for a second, okay? Before the cystoscope, what else you can do by this study? Are you still missing a very important phase?
We can see the delayed images of the study.
Nice.
Delayed image.
Okay. Let me give you the delayed image of the study. You can scroll?
Yes.
Okay, go ahead, scroll.
Yes, I'm able to. Now on the delayed images, I'm looking for the urinary bladder.
Okay.
So there is thickening is seen in the urinary bladder wall, especially in the left lateral wall.
Okay, you already told me there is thickening, and you confirmed the thickening in this urinary bladder. Okay, what else?
There's no interluminal mass is seen. And,
just let me stop you for this comment, because if you just give me a control for 1 second, okay? Look, trace this ureter, okay? Trace that one. You can trace with me? Stop. What is this? Okay, this is one thing, okay? Go more. What is this? Okay, go more. What is this? That one. Okay, just a second. And the ureter will go straight forward into the vesicular. Trace the other one. Okay. You got my point?
Yeah.
Let me show you something. Okay. Scroll in the coronal. Look. This is the calyx and proximal ureter. Go down. What is this?
Yeah, this is the mass in the ureter.
Okay. So this is okay. Describe this lesion for me.
This is this is poorly marginated, ill-defined soft tissue mass is seen in the distal mid ureter, which is causing irregular defect. So this likely represents
Is it unifocal or multifocal, intraluminal only, or intra and extraluminal?
This is a multifocal mass.
Okay. Can you see here? Can you spot it here?
Yeah. This is multifocal, and this likely be neoplastic in origin, considering the patient history of hematuria. This finding may represent TCC, transition cell carcinoma. This patient needs biopsy for further management.
What history you can take from this case? What you want to ask this case about?
I will ask the history of hematuria you told me, sir. And second, there is a history of any weight loss, any loss of appetite, any history of UTI, any history of
exactly recurrent UTIs, history of bilharzial affection, or history of prostatic cancer, or history of any chronic prostatitis. Can you state it? What is this inside the prostate?
This is I think posterior urethra is the posterior urethra. This is urinary bladder.
What is this filling? What is this filling defect inside the prostate? The one already the Foley's catheter balloon is landing on. What is this?
Posterior urethra.
Or this is post intervention inside the bladder.
Yeah, this is some extravidation of the contrast is seen.
Okay. Let me give you a clue. For this case, the moment you will deal with any case of hematuria, you should go straight forward for 2 scans, the nephrographic phase and the delayed image. Don't close your study without the delayed image. And the delayed image, you should highlight the entire course of both ureters and both renal pelvises and calyceal system as well. Okay? You told me it could be here, renal pelvis lesion, or multifocal, or even single focus inside the ureter like this one. You got my point? Yeah. If you see something like that, you should tell yourself, is that ascending metastatic process from underlying urinary bladder lesion, or even extension from prostatic lesion, or it is a primary pathology inside the ureter. So you will scroll down, you will see the entrance of both ureters. If you didn't see any lesions at the base or if you didn't see any lesion at the bladder, so bladder base especially, or even the prostate, so consider this one as a primary urothelial tumor. Okay?
Okay.
And search for adjacent lymph node and search for loco-regional lymph node inside the pelvis, like internal iliac lymph node, if you are suspecting the urinary bladder or the prostatic lesions, or even para-aortic lymph node if you are suspecting straightforward renal pelvis tumors or proximal ureteric tumors. Okay?
Okay.
You did very well, but it was a tough case because already we can appreciate this, but I know it is already the lagging inside the internet. If you already harden the image or do extended focus, see, it was there already inside the non-contrast. You got my point? So if you have a case of hematuria and you didn't find any obvious stone or obstructing stone inside the course of the ureter, try to remember that you will search about filling defect, like maybe mass lesion, or even more simpler than that one, the hematoma, ureteric hematoma from passage of previous stone. You got my point?
Yeah.
Okay, thank you for your answer.
This was the diagnosis. What was the diagnosis for this case? Ureteric
No, primary urothelial. And actually, he was done previously some surgical intervention with this prostate. Can you imagine? He had already central zone removal from the prostate.
Yes.
Because he had already chronic obstructive at this age. He had already chronic obstructive symptoms. Okay. And then he developed hematuria. Then they will start to investigate the hematuria to find this one. And this patient has already history of previous multiple urinary tract infections.
So this was the ureteric carcinoma of the left ureter. It was carcinoma of left ureter.
Multi-segmental, yes. Okay.
Yes. Okay.
You want to stay for the next one, or we can?
Yes, if possible. There's no candidate.
No you are the last one.
Please, Dr. Fathallah, you can give candidate number 13 another case, and then you can shift to candidate number 1.
Okay, no problem. Okay. You still have the control, and this is very straightforward the case. You go scroll.
Okay. Yes. No, I'm not able to scroll.
You are able to scroll.
Yeah, no, I'm able to scroll. So this is the CT scan. KUB. I will describe the. I will first of all scroll the images from top to the bottom. Then I will be able to describe my findings. So yeah, I am going inferiorly. So this is the female pelvis, and
okay.
So I'm going back.
Okay.
And here I can see that I could not see the urinary bladder is likely collapsed, and there is a moderate hydronephrosis is seen in the right kidney, with some cyst is noted in it also.
Which part of the right kidney?
Cyst. This moderate hydronephrosis is seen in the right kidney. Right kidney.
Okay. Which
right kidney.
Specifically, which part of the right kidney?
I think this is the upper and mid pole, but I will share it on the coronal images. That will be more easily.
Okay.
What is the upper, the mid and upper pole? I think. So the right ureter is also appears to be dilated.
Okay.
And there is thickening is mild. I'm going inferiorly. Right ureter is following on the psoas muscle, but there is there is slight thickening is noted in the wall of the right ureter, and it is going inferiorly. The right ureter, I could not see any stone in the right kidney, and the urinary bladder is I cannot see urinary bladder because urinary bladder appears to be collapsed. Now I will see the left kidney. As far as the left kidney is concerned, the left kidney appears to be left kidney appears normal. There is no hydronephrosis and no ureter is not dilated. So in this case, I am unable to comment on the urinary bladder which is collapsed. And the right kidney reveals moderate hydronephrosis, especially in the upper and mid pole. No stone is seen in the right kidney. Possibility of any mass lesion in the right ureter or bladder cannot be excluded on this non-contrast study. So the
what you will recommend in this case?
Post-contrast study is the device. If the renal function
just hold on for a second. Give me the control. What is this?
This one, yes, this appears to be bladder. This appears to be urinary bladder, I think. This appears to be urinary bladder.
That one.
Yeah, I think this is urinary bladder.
طيب, what you will recommend for this case?
The ureter which appears to be in the distal end appears to be sometimes elongated. So this could be represent ureterocele. Post-contrast image is advised to see the post-contrast image.
Just a second. Let me check first. You ask me for the coronal. Scroll the coronal.
Yeah, on the coronal images. No, I'm unable to. Yeah. No, I'm unable to. Okay. Yeah, this is the upper pole. You were asking me the hydronephrosis, various hydronephrosis. Hydronephrosis is seen in the upper pole. And there is small cysts are also seen in the kidneys, as in the liver. And
hypodense lesion or hypodense lesion inside the liver. Go ahead. Nice.
Yeah. So
what is going on with this right kidney?
There is some suspicion of small air loculi in it, in the bilateral pelvicular system. So I will confirm it on the Housefield's unit taking it.
Okay, stay with me. I will show you something. Show the contrast enhanced study. You can scroll.
Yeah.
Okay, go ahead.
No, I'm not. Yes, I'm able to control. So I'm going inferiorly. This is a contrast study. Here I can see the mild ascites is seen along the interior surface of the liver. The multiple cysts are seen.
You are talking about this one? Just a second. You are talking about this one?
No, we're talking
where
about
there is no ascites.
There is a there is a so I could not see any hydronephrosis in the kidney. Rather, I can see the low density areas are seen in the kidneys bilaterally. So these low density areas, I'm not sure what these are, what they are. These are some artifactual in origin, or likely it could be artifactual in origin. And I could not see ureter. Ureter is seen. It is dilated widely. I'm going inferiorly to see any mass in the ureter. So I'm going inferiorly. I want to look at the inferior end of the ureter, and here is the uterus, and
again you met up the cystic lesion.
So there is this small cystic lesion is seen, and the posterior spectral bladder on the right side, and it is not filling with the contrast. So this could be represent small diverticulum. Or small this cystocele, this one is this uretocele. I will.
You are doing very well. Continue. Don't be hesitated.
I want to see the delayed images of the studies if available.
Here is a delayed image. You can scroll.
Yeah, on the delayed images. Yeah. So okay. So this appears to be double pelvicular system, double moiety system, which is one of the moiety is excreting the contrast, and it is lower moiety, and upper moiety is not secreting the contrast properly. It is causing hydronephrosis. So upper moiety is concerned with the this formation of the uretocele formation.
Excellent. Yes, it is. So you are following what rule or what law?
Yeah. So lower moiety is the one is leads to reflux, and upper moiety.
Exactly.
lead to the ectopic ureter.
Can you please give me the control? Yes, that is actually a classic presentation of Weigert-Meyer law. This is duplication of the collecting system. As you stated earlier, you should tell this is upper calyx is extremely hydronephrotic with thinning of the parenchyma or mantle. So this is actually one collecting system, and this is the middle and the lower moiety or middle and the lower calyceal systems. They are joining the lower moiety. Then that one is running in the delayed image, and that one is obstructed by the ureter. The lower moiety will be liable for the reflux, and we should do for this case another study. Can you state what study we will do?
We could do the nuclear scan.
No, before the nuclear scan.
We can
if you want to confirm, can I tell from this scan I have a reflux inside the lower moiety ureter?
We can do the MCU scan.
Exactly, MCUG. We should go for micturating, or we can cancel the micturating. We will need just the refluxing study. You got my point? So we need to inject cysto urethrogram, and we can take the phase while it is already straining or micturating even, but it is a female, so it is hard to obtain the micturation. So only the straining phase, and we can check if there is any reflux or not. Okay?
Yeah.
You did very well. What about the lesions that you accidentally discovered inside the liver? Can you comment?
These are, I think, simple cysts are likely represent simple cysts, or could represent hemangiomas, because the contrast is there's pooling of the contrast is seen periphery. So these may represent hemangioma.
Nice. Can I confirm the possibility of hemangioma in this?
Yeah, this would be. Yeah, because there is peripheral pooling of the contrast, we can see the delayed image. So we can do the ultrasound of the images. This study. So in the delayed image, delayed image, these appears become isodense. So these are represent hemangiomas. This confirm this is hemangiomas.
Thank you for your participate with me. And actually, this was two tough cases, and you made both of them inside the ureteric pathology. Okay? Thank you for your cooperation with me. Can we shift?
Thanks a lot, sir. Thanks a lot, sir.
Can we shift to the other candidate? Dr. Muhammad told me
candidate number one, please. Candidate number one, are you present?
Assalamu alaikum, sir.
Wa alaikum assalam wa rahmatullahi wa barakatuh. Welcome back.
Thank you.
Yeah, okay. I approved you. You can go.
Okay, so I've been presented with the axial contrast enhanced CT lower chest and abdominal images of a patient, in which I would like to take a moment to scroll the imaging stack. So I would just like to go till the last cut, simultaneously noting for any significant abnormality. So I can appreciate that the patient is a skeletally mature adult male patient, and I can appreciate that there is some perirenal fissuring noted in this phase, which is the corticomedullary phase of the renal imaging, in which there is a peripheral cortical fissuring is noted. So there is some evidence of peripheral hypodensities as well, noted within the periphery of the left lower renal cortex. There is no evidence of hydronephrosis. I'm trying to look for the similar changes within the right kidney as well. So there is no evidence of any such appearance noted in the left kidney. Additionally, I can appreciate that within the splenic region, also there are some hypodensities are noted with some periphery, and which are in keeping with the triangular appearance and a low attenuation. So I'm thinking of multiple infarcts, or with the possibility of so I would like to take a history of any shock or any post-trauma history for the patient. Another possibility for this one can be polyarteritis nodosa, but that won't explain the splenic finding.
Exactly.
And that is more likely to be bilateral.
Okay, nice. So you are dealing with a case of renal infarction and splenic infarction. You describe it very well. Cortical, hypodense region, plus the striation. You did very well, and also you comment on the other side. But this one actually is more or less is going to the nephrographic phase, not the corticomedullary exactly. Okay.
Okay.
So what else you can check in this scan?
So I would like to check the vessels. Yeah, I would like to check the renal arteries for any abnormality in the both side. So I will like to come to the region of renal arteries at the level of hyla. So the renal artery on the left side appears patent. Can I check it in it is patent. Renal artery is.
Yes. Both of them are patent. Okay. Just to save the time, you describe it very well, very well. Actually, how you differentiate this one from the previous session cases like infection? Can you state it for me at least one or two clues for this one?
Yeah, for the I would like to differentiate from a closed differential, because it is a hypodensity having a triangular appearance, and it is not leading to any stranding in the perirenal fat, and no affection of the perirenal fascia is noted. Plus the perirenal area is very clean. It is not showing any stranding, and there are hypodensities which are triangular. Additionally, there are splenic same looking lesions as well. So I would like to keep a differential of infarct first. For that, I would like to see any
nice. Actually, you interpreted very good and concise to the finding. So you stated as there is already similar splenic finding matching with also with the infarction, and there is no significant changes in the perinephric fat. So I will stick with the infarction rather than the infection. And this is actually was a case of renal and splenic infarction. This case was a cardiac case presented with AF. Okay. At the same set, actually previous set for this one, he had right MCA infarction 2 days before this scan. Okay, just stay with me for another case. Okay.
Okay, sir.
Can you please scroll?
Okay, I've been presented with the axial contrast enhanced lower chest CT and abdominal CT imaging in a patient. I would like to take a moment to scroll the imaging stack, simultaneously noting for any significant findings. So there are, in my first scroll, I can appreciate that there are bilateral cystic lesions are noted in both the kidneys, which are innumerable, and in the cortex, and they are distorting the renal parenchyma. And some of them are they are variable in sizes. Additionally, I can appreciate that there is a perinephric collection extending into the perirenal spaces and the perirenal.
Right or left?
On the left side. On the left side. And I can also appreciate going down into the region of the pelvis that there is a soft tissue density lesion noted in the dependent most portion of the bladder as well. So findings are I would like to move to the region of interest. So this is the posterior. There is a hyperdense collection noted posteriorly in the kidney. It is hyperdense relative to the normal renal tissue, and it is a study has been taken in the arterial phase. So I've been looking for active arterial extravasation, which I'm not able to appreciate. And I'm also trying to look for any evidence of fat containing lesion. I cannot appreciate any cyst containing fat. So the hyperdensity is in keeping with the hematoma. I would like to trace the region of pelvic ileal system to look for extension of hyperdensity within it. As there is
Can I see with you the second phase of this study? Okay, this is the second one. You can scroll and continue your good interpretation.
Okay, so I will like to see the region of pelvic ileal system as it is quite distorted. So would like to carefully, normally I follow it anterior to the Psoas region, but I'm not able to appreciate it in anterior to the Psoas. And there is, so in the delayed, it is hyperdense within the delayed imaging as well. So I'm thinking of a ruptured cyst with the urinoma formation. with urinoma formation.
With urinoma formation type, how you already, what we are actually, we are missing one very important inside this study, the delayed image. But let me scroll with you one thing and just tell me what is this, okay? What is this?
Okay.
Tell me, can I ask you for one thing? Why we did this scan in 2 phases or even 3 phases, but I forgot to bring the most important delay phase. Why we did this scan?
So to look for any active arterial extravasation, it is in
How
the
you
arterial.
How you confirm with the arterial?
In the I will confirm it in the plane. Would like no, I can't see it in the
There is no
plane.
action. Okay. Actually, if we are searching for any active contrast extravasation inside any study, even for the trauma cases or even for the something like that with polycystic renal disease, we should compare the 2 phases. If we saw any focus with continuous contrast filling, like this one and that one, we should consider this patient is going for active extravasation of the contrast. You got my point? See, you can see this point.
Okay.
Okay. What happened here?
So there is the filling. This area showed persistent filling.
Exactly, persistent filling. You can see this one.
Yeah.
What happened here? It is
yeah,
still,
it is
yes. And this one
persistent
is,
filling.
yes. So in order to this one, you will refer this case to which subspecialty?
So I will urgently communicate it to the intervention radiology department.
Exactly. Yes. Yes. See, now this study can change your management 330 degree. You got my point?
Yeah.
You should see. But what happened with this case? You give me a clear diagnosis of this case.
So it is active arterial extravasation with the perinephric. In a case of polycystic kidney, autosomal dominant polycystic kidney disease with perinephric hematoma and extension of the hematoma into the bladder.
Exactly, because this patient actually was hypotensive. This patient was actually hypotensive at this time. So immediately they shift him into the interventional radiologist, okay, to embolize this bleeder.
Okay.
You got my point? But you did it very well. You stated already this could be hemorrhagic cyst rupture or even intrarenal aneurysmal rupture. What else you know about this polycystic disease? They have a specific type of aneurysm.
So they are known to have 20 to 30% patients can have a berry aneurysm in the brain. So I will, after stabilizing the patient, I will advise a cranial CT angiography.
Exactly. Yes, we should screen this cranial vessel to check for another possibility of another one. What else can be missed in this scenario?
They are associated with hepatic fibrosis, so we'll advise a hepatic study after it. And
No.
LFTs
Intrarenal. What else we can miss inside this one? The moment we
any
have polycystic.
enhancing mass, any enhancing mass figure?
Exactly. Yes. We should look carefully after we stabilize the case. We should look carefully for second look for any hidden RCC inside this patient. Okay.
Okay.
You did very well. Really, you did very well in this one. Thank you for your 2 cases and 2 discussion with those 2 cases. Can we go for candidate number 2?
Yes, candidate number 2. Are you present? Candidate number 2. Candidate number 3.
Yes, I'm candidate 3.
Yes, go ahead.
Okay, go ahead. You want to scroll or can I scroll for you?
Okay, you can scroll for me.
Okay, no problem.
Okay, so I'm presented with CT scan axial sections, post-contrast in arterial phase images. And here I can see that there are patchy areas of...
If you please, can I stop you for 1 second? Don't state if you are talking inside the genitourinary, don't tell it is arterial phase. Okay, so what is this phase?
Corticomedullary phase.
Okay, you can go.
Yeah. Okay.
Corticomedullary, you can go.
Corticomedullary, yeah. So I can see that there are ill-defined hypodense areas seen in the left renal parenchyma. These are triangular shaped, and there are also some rounded hypodensities noted in the left kidney. There is a mild perinephric fat staining also seen.
Nice. Okay.
Yeah. And I do not see any hydronephrosis or any obvious calculus. Yeah.
Can I give you the second phase? Okay.
Okay.
Okay, go ahead.
Okay, so in the nephrogenic phase, I can see that there are now prominent these hypodensities noted in the left renal parenchyma, and there are contrast seen in the left in the right renal pyramids. On the left side, there are I think some delayed nephrogram.
They are matching together. See, this is the nephrographic phase. Okay.
Yeah,
but now you can see more appreciated of this hypodensity.
Yeah, they are more prominent now.
So that is give us the first question in this case. Which best phase you can appreciate the renal pathology? Is it corticomedullary or nephrographic phase?
Nephrographic phase.
Nice. Okay. So it is nephrographic phase. The moment you will see any study, and if you have short time to review first the nephrographic phase. Okay.
Okay.
Right. After the nephrographic phase, that is the delayed phase.
Okay.
Okay.
Yeah. So in the delayed phase, I can see that there is normal excretion of the contrast into the renal pyramids and also into the bilateral ureters.
Okay.
Yeah.
Can you please give me a diagnosis in this case?
Okay, my differentials would be that there were hypoattenuating lesions, so it could be lymphomatous deposits. The possibilities could be of pyelonephritic foci of the pyelonephritis.
Okay.
Yeah, and other differential could be of less likely renal infarcts can also be one of the differential.
Because we stated earlier in 3 or 4 cases before that there was a case of infarction without any perinephric affection.
Yeah.
At this case, you have what is this? What is this one?
This is rounded hypodensity seen in the renal parenchyma, having cystic appearance. Yeah, somewhat hypodense. Yeah, appearance.
Can you give me a differential for this one?
It could be a simple renal cyst or could be fluid collection with some enhancement.
Exactly.
Yeah.
Nice. You got it very well. Actually, we have a multifocal, cortical and subcortical, or even cortical and parenchymal areas of hypodensity or hypo enhancement or hypoperfusion in the nephrographic phase, along with alteration of the parenchyma here.
Yeah. Okay.
So this is actually very similar to the previous case of infarction, but we have here that one.
There's some perinephric fat staining and mild thickness of the Girota's fascia as compared to the contralateral side.
Exactly, and we give diagnosis of this one as a multifocal pyelonephritis in the left kidney with a small hypodense abscess formation, parenchymal abscess formation. Okay, for follow-up. But you did very well. Okay.
Okay.
Of course, other differential are extremely excellent, but first you want to ask about the fever and yes, exactly. If there is any cardiac disease, if I'm suspecting that this could be infarction, but this is not infarction, there is a changes in the perinephric fat planes.
Yes.
You got my point? Okay.
Yeah.
Can we shift to another one to see a lot of cases? Actually, we discussed this one in the last session. You were there attending?
Yeah.
The last session?
I partly attended this session.
Type. You want to participate in this one also?
Yeah.
Okay, you can. I will scroll for you.
Okay, so this is unenhanced study, CT scan, axial sections of the abdomen. As I'm going down, I can see that there is a mild distension of the stomach. Okay.
leave the stomach by this device.
Okay,
I will
yeah.
tell you later.
This is a
Focus
PEG
on
tube,
the.
maybe, yeah. Okay. So there is some left renal mass lesion maybe on the unenhanced study. There is also thickening of the Girota's fascia on the left side and also perinephric fat stranding noted on the left side.
Okay.
And thickening of the lateral conal fascia and interior Girota's
Nice.
fascia with perinephric
Exactly.
fat stranding.
Exactly. Okay. What you will recommend or what you will give me?
I
for
will
this
like
one?
to see the post-contrast images for further evaluation.
Okay.
Okay, so on the post-contrast images, I can see that there are multiple hypodense lesions involving the left kidney.
Okay.
Yeah, the largest one seen in the upper pole region. However, there is no hydronephrosis seen, and these regions are again ill-defined.
Okay. Cortically based.
Cortically based, yes.
Okay. Inside this nephrographic phase.
Yes,
Okay,
and
good. You are doing.
there is also a mild loss of continuity with the cortex, I guess. It could be due to any rupture.
What is this?
Yeah, it is perinephric collection or perinephric abscess. Perinephric
Actually, you can give more precise. It is subcapsular collection because
subcapsular, yeah.
already yes, this is the perinephric. This
Yeah,
is the
because
subcapsular,
it is
and this is
indenting the capsule of
nice.
the
Yes,
vein.
it is scalloping and indenting. Okay, so this is
Yeah.
the second one, the second phase.
All right, so it is more prominent in this nephrogenic phase. And I will like to further also see the excretory phase to complete the study.
Let me ask you one question. Don't forget this one. Okay?
Right kidney. So yeah.
Exactly, yes.
Okay. So in the right kidney again,
Dr. Muhammad stated in the last session, don't be saturated by one finding.
yeah. There are also hyperdensities noted in the right kidney as well. Ill-defined hyperdensities in the cortex of the right kidney as well.
Okay. You got my point. So this is the first and second phase. We don't have delayed because they already did this scan for mesenteric vascularity. What you can give me for differential diagnosis of this case?
Okay. So okay, so this is again these are the foci. It could be the foci of pyelonephritis with adjacent subcapsular collection formation on the left side.
Yes, so it is bilateral multifocal
Pyelonephritis
affection, yes, with subcapsular collection, or you can state it abscess because it is already here and extending of this inflammation into the
contained rupture of this one of the
exactly, yes, and this is very clear and classic case for bilateral affection. You can see the second phase, it is here.
Yeah, now I can see that there is enhancing walls around this collection as well.
Nice. So we can differentiate this one from the infarction by the extra renal finding. So the moment already you will be biased by is it infarction or is it inflammatory process, stay away from the kidney and look for the extra renal space and other organs. So it can help you to minimize or to define your diagnosis inside one state only. Is it infarction? Is it pyelonephritis? Okay.
All right.
And if it is pyelonephritis and it is extending like that one, you should ask for the delay to
just
state
see
from that. See, there is
I can
enhancement.
see there is enhancement of the ureterial lining of the left ureter, suggesting some element of ureteritis also.
Nice.
Myelitis also,
You are doing very well. Nice. Thank you for this participation, and we can shift to candidate number 4, I guess.
Yes, candidate number 4.
This is Dr. Muhammad from the last session. We can take 2 cases.
Yeah, candidate number 4 or candidate number 5.
I am.
We are repeating some of these cases. This one or these cases. Yeah, we presented these cases before in the last session, but we are repeating now these cases. Yes, go ahead.
Okay.
You
provided with.
Okay.
I'm provided with CT, abdomen, plain images. Here I can appreciate that the left kidney appears to be relatively enlarged as compared to the right side. There is a mild to moderate left-sided hydronephrosis.
Okay.
Along with there is fat stranding and thickening of the anterior and anterior perineal fascia and lateral conal fascias.
Okay.
Now I'm looking at the
let me go back for the kidney. Okay.
So
okay.
These fat strandings are extending inferiorly into the left iliac region. I can appreciate a focus of air within the
nice. Yes, exactly. Which way?
Left renal pelvis extending into the left ureter.
Okay, nice. Here.
So, as there is marked fat stranding in the renal hilum as well as in the perineal fascia, along with the diffuse enlargement of the left kidney and mild hydronephrosis, I'm suspecting infective disease process, pyelonephritis with air locules in the emphysematous pyelonephritis.
Exactly, yes.
Pylitis, because I cannot appreciate air into the renal parenchyma.
Nice.
I will look at the distal ureters as well as in the urinary bladder to look any other air foci or source of infection in the urinary bladder.
Okay.
Urinary bladder.
Do we need contrast for this case?
Yes, we need contrast because I want to see the lining of the ureter.
Let me review with you the contrast.
And the enhancement of the kidney. So this is the corticomedullary phase of the kidney.
No, this is still.
Sorry.
No, nice. You are good corticomedullary. Okay.
Okay.
Continue. I'm sorry.
The left kidney shows normal. Left kidney parenchyma shows normal enhancement. I cannot appreciate any evidence of. There is. I cannot appreciate a definite evidence of any abnormal enhancement in the left kidney. But I'm looking at the. I want to see the lining of the ureter. There is mild enhancement of the ureteric wall.
Let me get you the ureter in the second phase. Okay, this is the second phase. Okay. Can you see that one?
Yes. The left ureter shows mild. There is a hyperdensity within the area of the left ureter.
Exactly that one.
Yes.
Exactly that one. What happened? What happened again? What happened? We stated one case before. What happened to the function of the kidney? This is the.
There is mildly delayed function of the left kidney. There is decrease.
Okay, if you have multiphasic kidney, don't forget to comment on the function. Yes, yes, exactly. So it is an obstructing stone.
Yes, there is an obstructing stone in the left proximal ureter causing obstruction leading to the pyelonephritis.
Nice. Emphysematous pyelonephritis.
Of the left kidney.
So as we stated earlier, what should you search for in this case? You will be satisfied in this case, or you will ask for the delayed?
I will look at the delayed imaging also to see the excretion of the kidney. I can again appreciate the same findings with the delayed excretion of the left kidney.
So can we call it obstructed kidney?
I cannot appreciate. Yes, this is an obstructed kidney with the no excretion in the ureter, left ureter.
Okay. Actually, the neurosurgeon will the neurosurgeon will ask you a specific question. Is that obstructed kidney? is that pyelonephritis, emphysematous pyelonephritis / emphysematous pyelitis, which is the less severe form, or can we wait for this one with medical treatment? The moment you will tell him there is obstructing stone and it is obstructed in the delayed image. Okay, you can continue.
We cannot wait for this patient because there is obstruction leading to the emphysematous pyelitis. This is a
and actually this emphysematous, yes, this emphysematous pyelonephritis or pyelitis, this have a high mortality.
Yes.
So the patient must be relieved and the kidney must be relieved. So we are meeting a case of emphysematous pyelonephritis or emphysematous pyelonephritis plus pyelitis with obstructing proximal ureteric stone and the extension of the air inside the proximal ureter, along with perinephric collection. Okay?
Yes. Okay.
Can we take another final one with you? We actually made this one before.
Okay.
And Dr. Muhammad already gave us a similar case today.
This is the CT. This is the CT abdomen.
Okay.
Corticomedullary phase of the kidneys, in which I can appreciate that the right there is hypodensity around.
Can you please raise your voice, candidate number 5?
Okay.
Okay, sir. There is I can appreciate there is hypodense collection around in the perinephric space of the right kidney. Okay. As well as there is dilatation of the right pelvic ileal system. There are multiple calculi within the right kidney. I can also appreciate a hypodensity within the renal pelvis.
Okay.
This hypodensity is extending inferiorly into the along the anterior aspect of the psoas muscle.
Okay.
There is also adjacent fat stranding. So inferiorly it is extending up to the right iliac region. Urinary bladder appears normal. So I'm suspecting that there is this low density. I will, in my usual practice, I will take the density of the low density. This appears to be air to me. So I'm again suspecting an infective disease process with perinephric.
This one you are talking about this one.
Yes, these densities.
طيب, can I give you another clue? This is fat density. Okay, this is by minus. Okay, so this is not air. Can we mute? Okay, you can continue.
I'm suspecting that then if this is the fat density, I'm thinking about the xanthogranulomatous pyelonephritis with multiple calculi in the right kidney and this disease process extending into the along the right psoas muscle.
Can we already? Okay, this is a good differential diagnosis. What you want to ask for before jumping to this diagnosis?
So I want to see the other phases, excretory phase.
You told me which phase is this one? Is that
this is the
cortic?
No, this is the nephrographic phase.
Excellent. Yes, because already we are looking for the normal kidney to judge the phase, not the diseased one.
Phase.
So this one is obstructed.
Yes.
Yes, sir.
Okay. This is the delayed image. If you please comment.
On delayed imaging, there is I can appreciate contrast within the right pelvic ileal system.
Nice. Okay. So there is
but
maintained.
There is no evidence. I want to see the excision of contrast into the right ureter. Can you please scroll it again? Yes, I can see there is contrast. This hyperdensity was also present on the plane images.
Okay.
There is no contrast into the excretion into the right ureter.
Okay. So what can you give me in your diagnosis for this one? You're doing good. What you can give me in your diagnosis and what you want to ask about in this case? See, I give you the coronal to check the extent.
So this is an extensive disease process involving the right kidney with internal fat and obstruction of the right kidney.
Okay.
There can be the first differential which I was thinking about was the xanthogranulomatosis pyelonephritis, other differential, anicalicial rupture due to obstruction leading to urinoma formation.
Oh, this is not
But
urinoma, and this is
I
you
cannot
should.
appreciate it. Okay.
Let me tell you what we did in the last session. We told this is a perinephric collection or infected perinephric collection. We should exclude the possibility of urinoma, so we can check the delayed image. Okay, there is no contamination of this collection by the excreted contrast, so this is not a urinoma, but it is already compromising the right ureter and the excretory phase of this kidney, because already we stated earlier it is compromised. This kidney was inside the nephrographic phase, and this was inside the corticomedullary phase. Okay, so we should ask about specific questions. If this patient has recent ISWEL or recent ISWEL, extracorporeal shockwave lyso. Okay, you can hear me?
I was not able to hear.
Does this patient have a recent surgical interference like ISWEL?
Okay.
Patient, yes. This is very good question for him because already he had multiple stones. So this could be fragment. And this is post-traumatic or post-procedure infected hematoma because already there is a stranding of the surrounding fat balloons. You got my point? Second most important point is to check the kidney itself for coexisting pyelonephritis or even abscess formation, because this is very important for the clinician. What I will do with this case, should I only insert double J or should I ask the interventional radiology to evacuate this hematoma for me, or this patient need more massive maneuver to treat the kidney? My point? So he need a specific answer for a specific questions. Is that urinoma? Yes or no? Is that compromising the kidney function associated renal affection of this inflammatory process or collection? Yes or no? And if there is any calcium rupture inside the delayed image. You got my point?
Oh, yes.
Okay. Actually, we took a long time from Dr. Muhammad, I think, and he gave us a very good first session about the retroperitoneal masses.
Sir, can you please explain this case again? Was it hematoma or was it an abscess extending after ESCL?
Infected hematoma, post-ISWEL. That was infected hematoma, post-ISWEL. And they were suspecting this could be urinoma, not hematoma.
Okay, thank you.
You got the answer? And he was needing a specific questions. Is that compromised parenchyma or not? And is that obstructed ureter or not?
Dr. Fathallah, really, I would like to thank you so much. Really. Your cases, most of your cases were challenging, really, were difficult. We are highly appreciating your maneuver, and really your discussion was very deep with the candidates, and really the candidates did very well, but really still some cases are challenging for all of us. Really, I would like to thank you so much. Your cases are so amazing, and I hope you can continue with us in the next genitourinary session, inshallah. I think, inshallah, I hope so. Really,